Now we move on to our much awaited section, that is a cadaveric demonstration. So we'll see our masters in action now. We have the first one will be cadaver demonstration in the sagittal plane by Dr. Paul Gardner. This is an interactive session. You can shoot questions to our doctors there.
We're just starting the cadaver dissection. The only thing is that cadaver is still a bit frozen, but I'll just write what I can do for that. Section, can I get the sections? Okay, so you're getting the video, right? So for the beginners here, let me just show you how to hold the endoscope and how to place it in the nasal cavity, because we are going to do the four-handed technique. And a lot of ENT surgeons, can you have the external camera? Can you focus here? Here, can you show this one? External camera. Okay. So generally for the fist surgeries, we have the habit of putting the endoscope like this. We'll place it inferiorly on the mid part of the nasal cavity. I can just show it with the other thing. Can you connect the endoscopic camera again? Endoscopic camera. Because this is actually a very important thing, because many of the neurosurgeons and ENT surgeons, when they start doing the endoscopic skull base, they have a tendency to put the endoscope in the inferior part of nasal cavity like that. And the fist surgeries, we generally do it by putting the endoscope in the mid part like that. But for the skull base, we need to put it like that on the roof of the nasal cavity. So we have to put it here in the superior part of the nasal cavity. The endoscope should be parked here, not here or not here, like the fist surgeons generally do, right? So this is the part for the endoscope, and this is the corridor for the instruments. So let me start with the nasal face. So right nasal cavity, and this is the inferior turbinate, that's the middle turbinate, and this is the septum, and that's the uncinate process, and this is the bulla ethmodalis. The first step in any endoscopic skull-based surgery is the exposure, and for that I need to generally outfracture the inferior turbinate by using the blunt side of the elevator like that. That is what I generally do. So now I get an extra corridor to place my instruments and suction there. That's the first step. And the second step for me is to take the elevator like that. I come to the bulla. With the elevator, I just take up the ethmoids in one scoop. That is my second step. കുറച്ചുകൂടെ വലിയ മോണിറ്റർ ഉണ്ടോ? കുറച്ച് ക്ലോസ് ആക്കണം. Can you bring it a bit closer? Yeah. Or can you push this one, Pran? Okay. So that's the second step. So outfracturing inferior turbinate, taking the ethmoids away like that. Then I can take the Blackesley and take this off. Straight Blackesley. They have another, you have to help me, okay? Straight Blackesley. The tissues are still a bit frozen, that's why I'm finding it a bit difficult, but it's a very easy thing to do. Clean. Pituitary forceps, there's a pituitary forceps. Give that one, yeah. So this is actually a bit different from what many others do. They don't remove the ethmoids like this. They just go to the posterior ethmoid. But I generally do this ethmoidectomy in all my pituitary exposures, because that doesn't add much to the morbidity at all. And that helps me to preserve the middle turbinate many times. Can I get the elevator again? My third maneuver is to push the middle turbinate laterally like that. Right, now you see the superior turbinate. Section. So this has created this extra room. This turbinate, inferior turbinate lateralized, middle turbinate lateralized. So now I have this room to work here and visualize the flap pedicle section. What is that actually? No, is it some ice or some cotton? I don't know. Oh, I don't know what that is. Okay. Okay, right. Elevator. So now you are visualizing the superior turbinate. So that's a superior turbinate. Once I lateralize the superior turbinate, in some cases, like in 20%, you'll have the supreme turbinate there. That's going to be supreme turbinate. Here the superior and supreme are fused to the single superior turbinate. This is a single superior turbinate. And some cases you'll have the fourth supreme turbinate there. So once I do that, I can see the sphenoid ostium. And if you don't see the sphenoid ostium, just glide your elevator like 12 millimeter up from the coina. 1, 2, 3, 4. And just above that, if you dip inside, you'll get the instrument will go in and the fontanelle there. That's a superior, that's a sphenoid ostium. Suction. And one of the most important or the most crucial things in the skull-based surgery, in endoscopic skull-based surgery, is the flap. Because before the advent of flap, the CSF leaks rate were like 20%, and with the flaps, it dropped down to like less than 2%. Can I have the elevator again? Elevator? Cortical elevator? Okay, so this flap actually is based on the branch of the sphenopaline artery called the posterior septal branch. So the sphenopaline artery would come here, it will come out like that from there, and it gives two branches. The posterior septal branch would run like that onto this area below the sphenoid ostium. So this flap is actually a flap based on the posterior septal branch. We are going to take the entire nasal septal mucosa based on this artery. Section. Sickle knife. So coming to the incisions, the sickle knife. Okay. So we generally use the 11 blade or a Colorado needle for this flap, a monopolar needle. So this is the coina. We are actually not seeing the coina properly because of this. May be a tumor also. I think it's a clival chordoma. Paul, is there a clival chordoma here? I don't know. Okay, right. Okay. So coming to the incisions. So this is the coina. The inferior incision actually arches along the coina like that. Unfortunately, we are not seeing the incision tube orifice here. So from the posterior tubal fold, you have to take it like that along the coinal arch. Like that. Don't go down to the soft palate. Come a bit anterior like that, there. And then you glide it down into the floor of nasal cavity in case you need a bigger flap. You can stop it there and take it along here like that for normal cases. If you need an extended flap, you can take it all the way down like that, include the floor of the nasal cavity. You can also include the inferior turbinate mucosa if you need. That's the inferior incision. Now coming to the superior incision, that's the sphenoid ostium. So we have to cut through the midpoint of the sphenoid ostium like that. And then you arch it up, and this 5 millimeter of mucosa there, that's a olfactory mucosa. You can see the color difference. This is the normal, this is a non-olfactory area, and this is the olfactory area. You can see the pale, much more pale color there, right? That's olfactory mucosa. You preserve at least 5 millimeter mucosa there. Come anterior like that. Come in till the level of the middle turbinate anterior level. So once you reach there, you can take it all the way up to the roof of the nasal cavity because there is no olfactory mucosa anterior to the middle turbinate. So beyond here, in front of that, there is no olfactory mucosa. Now you can take it all the way to the roof of nasal cavity. But if you are using a Colorado tip or a monopolar needle, take care not to cut through the cartilage because if you cut through the cartilage, you can have a saddle nose deformity in the posterior period. So come like that till the junction of the skin and mucosa there. Right? So this part sometimes can be a bit blind. You have to do it with a feel, but or else you can park the endoscope into the floor of nasal cavity and look up like that. Okay. Now let me complete the inferior incisions. So the inferior incisions, so generally we run it along the floor of the nasal septum like that. And here you have a spur, but you have to be careful when you raise that mucosa over the spur. You can get a tear there. So come anteriorly, can come till the junction of the skin and mucosa. And here you connect the superior and inferior incisions. Can you clean this one? Okay, that's where you connect this actually the junction of skin and mucosa. Or you can keep this level. This is the inferior, this is the anteriormost end of the inferior terminal. You can have this as another landmark. The more anterior you come, the more is the crusting. Also always remember that. Can I get the elevator now? Lemon blade. I think because the tissues are a bit frozen, it's not actually cutting through that. Okay. Elevator now. The caudal. So then you take the caudal elevator. And get this submucoperichondral dissection. Look how I move my elevator. Just glide it like that, dissecting the mucosa, the mucosal flap away from the cartilage. Somehow there is some problem with the color contrast. I am not getting the normal color here. Okay, right. Okay, so just keep moving like that. There are two things which are bothering me. One is the tissues are a bit frozen that I'm not getting a normal feel. And the other thing is a little bit different color contrast. Okay. So that is actually the base of that's the sphenoid rostrum. You can see this is the sphenoid rostrum, this is the ala of the vomer. Can I get the normal scissors? See, when there is a spur like that, you can of course prevent that by just doing a fracturing the septum like that and releasing the tension there. You can actually prevent that tear. But since I was doing a bit fast and this generally this can be always prevented. It's not a common thing. But if this happens, you can always put a mucosal flap over that and suture it, or just put a fasciolator. Scissors. Normal Mayos scissors. Mayos. Savlon. And those incisions which I made with the sickle were actually not complete. It was not going through completely. That's why you have to cut it now with the scissors. Look, now I am preserving this olfactory mucosa. It's olfactory mucosa. I need to preserve that. Elevator now. And then you park this nasocystal flap in the choana, nasopharynx. Or if you're doing a clival tumor, you have to open up the maxillary sinus there and park it in the maxillary sinus. Scissors, micro scissors. The code, the right code. Okay, whatever it's. Punch, Kirsten's punch, the one punch. Okay, elevator. So that's a flap done. So that's a L of Boma. You can go till that suture line there. That's actually the spinal process of the palatine bone coming up there. So that is till that's here to keep the flap, elevate the flap till that level, till that suture line. Right, now on the other side, I just quickly finish it off. Now, again, the out fracturing of the normal elevator, other elevator, elevator. Again, the same thing, the out fracturing the inferior turbinate. And I do the same ethmoidectomy with the elevator just like that. Pliciously. Clean. Elevator. And then the out fracturing of your middle turbinate. And can I get the trocar forceps? And that's a superior turbinate. That's a posterior remote cell. We can cut this inferior part of the superior turbinate. I think now the ice is melting. You're seeing the saline there, section. So that is exposure on this side. And this side, and for the reverse flap, coming to the reverse flap, elevator. You raise this flap on this side. Now there is a raw area here. I can cover this either by taking a free mucosal graft by cutting this part of the septal mucosa, because this anyway we need to remove that for the binocular approach. Or I can rotate this entire mucosa based anteriorly. I just cut it like that here, cut it there, and keep it based here, and then rotate this flap and bring it here. Can I get the knife? Section first. 15 blade. Or 11, whatever, 11, okay. We need a longer BP handle, okay? So you can cut this mucosa like that. And when I do that, you will get the septal branch here. You have to cauterize that bleeder there. Can I get it? I need a longer handle, okay? Elevator. Now I can remove this posterior septal bone and the cartilage completely, so that I can remove it till this level, till the level of middle terminate. See, when you start working more and more with the neurosurgeons, you will end up removing less of that. But for a beginning few cases, try to remove it till this level. Legs. So that is the sphenoid rostrum now. That's the other side, sphenoid ostium. Legs forceps. Legs forceps. They one. Legs forceps. So this is the typical owl's eye appearance. There are people say this is owl's eye appearance because he has these two sphenoid ostiums and the sphenoid rostrum there. And that's a suture line on the other side. Scissors, myoscissors. Elevator. Blackesley forceps. So that is what you call the reverse flap. Blackesley is not holding it. And the different pituitary forceps. I remove that one from that. So you can bring this entire mucosa anteriorly and suture it to the septum so that this raw area is covered and the crusting can be decreased. Can you hold it like that, Devanam? Can you hold it like that, like elevator? Paul, I think you are ready to come in, right? Yeah. Can you put it that side? Stop. Enough. Leave it, leave it. Release, 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 release. So you can switch this to the septum, and that will prevent the crusting in this part. That is called the reverse flap, right? Or else what you can do is you can just remove this mucosa. Scissors, 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 please, scissors, Mayo scissors. Blackesley? Yeah, please do. So you can remove this mucosa as if, and you can use this as a free mucosal graft to cover the raw area of the septum. You can just put it here and switch it as a free graft. Section. Do you have a chisel hammer? Somebody, Devanand, we need a chisel hammer from the Sandhu Surgicals. Drill ready, no? Drill. Metronics cutting drill. Cutting drill, cutting drill, cutting drill. So the next thing is to remove the sphenoid rostrum by making a cut there, another cut there, and then connecting it like that. Kerrison sponge, size 3 big punch, bigger one. You can do that by using a drill, or you can use a kerosene sponge, or you can just use a chisel hammer. Clean. Oh my God, that sphenoid is completely filled with ice, man. Devanand. Yeah, you have to put some hot water inside. Okay, section. That is hot water. Like, what's the temperature like? Can you increase it? Nalla choodulla iruthe. Kuruchoodu choodu vena keto. Yeah. Chisel. And we need a bit more hotter water. Chisel, okay. So this part I can actually, if I want to remove it quickly, I can just look how I hold it. I control that here with my finger so that it doesn't get slipped away accidentally. Hit. Okay, good. Enough. Slow. Hit. You can do that with the drill also. Okay, enough. Take care you don't cut through the flap. Chisel. Enough. Chisel. Can you get the legs forceps now? Section. Legs forceps. Do a big kerosene sponge. What is 4 mm kerosene sponge? Okay, there we go. Wait. I think this is a bit, maybe you have to decrease the table height. Is it okay for you, this table height?
Mm-hmm. Yeah. We'll make it work.
Okay, there we go. Done.
Okay.
With a second monitor, can you get a second monitor here? Yeah.
Yeah, or move the monitor over this way a little bit so he can see.
Yeah.
You want to increase the aperture on the scope too?
Yeah.
Yeah,
Yeah.
that'll help, yeah. Yeah, but we need this.
We need a
camera over
bigger
this way
zoom. Okay.
so he can see it.
Yeah, now it's working. Yeah.
Just move this way a little bit. Yeah. Yeah, these
Yeah.
little details of the ergonomics are actually very important. You know, for Dr. Felix, for us to be able to work, we need the monitor in front of us here. So we really need the monitor right here, if we can. Otherwise, he has to look over his back, which is going to be very difficult. Let me see. Yep.
No, we can. I think we can put the cadaver. Sorry.
This is clogged. It needs to be flushed. We can turn this table.
We can
too.
turn the table. 1 minute. 1 minute. It will change the table.
Oh, I think.
Nino can look on the table. Shift it along.
Ready? Get 1, 2, 3. It's
Okay,
stuck
okay.
on something over there. Something stuck on that side. There we go.
Okay.
There we go.
Yeah, now better.
And then if we can flush that, were you able to flush it? Yes. Yeah, okay, okay. Yeah, okay.
No, it's okay. I forgot to do the zoom. That's why.
Suction is max, yeah?
Section, section.
Okay, and can I get a drill, please? Oh, completely frozen.
Completely frozen. That's what I'm feeling. Okay.
All right,
Or should we
it's
wait
okay.
for
It's not gonna help.
some other session come back because it's, I don't know, you can,
Yeah,
let's
where
try,
is it?
right?
You can try to work through it a little bit. Do you have a...
We have a navigation.
Do you have a kerosene? Kerosene 2? Do you have a 2? Yeah. In my hand, yeah. Thank you. Yeah. So, Vinod has done a beautiful, very wide exposure, but I need to see all the edges. Clean, please, clean. Very wide sphenoidotomy. I talked before about how important a wide exposure is, and it really is critical. Let me see. Now, the rostrum has been removed, which is very helpful because having access to the floor of the sphenoid, pituitary.
One more section.
Pituitary. It's very high, isn't the cadaver, huh? The table. So I'm just going to clear some of the ice out here. Clean. Yeah. And let me see up here. So one thing that's important also about the working together side by side is that the view is not necessarily centered. Kerosene, again.
It's
Really high.
already still there.
Yeah. So a little bit of an ethmoidectomy can certainly help our view and our access. So I want to make sure that I don't run into something I don't mean to. So we're going to clean out up here, and we start to see the optic there at pituitary. Now septations, pituitary please, pituitary. Septations always run to the carotid artery. So if you see a septation like this, we have to assume at some point it's crossing the carotid artery. Clean.
So before that, all the mucosa should be removed, no?
The
mucosa lining should be removed.
It depends. Yeah. So if we have a nasal septal flap, we
Yes.
want to remove all the
Yeah.
lining. If we don't
Yes.
have a flap, clean.
Yes.
If we don't have a flap, we don't want to remove it. Through cut, please. Through cut. Okay. Kerosene.
Saline to me, some saline to me.
Let me see on the right side now. Yeah. So sometimes a little bit of the superior turbinate, you're a little twisted there a little bit. So this reverse flap, if we didn't suture it, let me have a backbiter. So normally suturing this reverse flap, it won't be in our
So
way.
is a debrider connected?
Backbiter.
Debrider connected, no. Tara.
But because we didn't have suture to hold it into place,
The debrider.
I'm just going to remove this reverse flap so it doesn't get caught in our suction. But the reverse flap is very useful. It really prevents nasal morbidity, and the nasal healing is very, very good. Clean, please.
That's clean. Done. Already done. Finish.
Let me see the reverse flap again. Come back. Oh, yeah. Reverse flap.
Wash.
Reverse flap. Yep. So you do have to remove a little more of the posterior septum to do a reverse flap to get it to meet, but that's okay because the posterior septum is not critical.
Wash.
The anterior septum is very important though. Ethmoid, pituitary, pituitary. So how much mucosa you remove really depends on the surgery that you're doing. If you have a small microadenoma, there's a little bit of that reverse flap left. If you have a small microadenoma, then you want to leave the mucosa. If we have a big nasal septal flap, you have to remove the mucosa or the septal flap won't stick. Here we see more septation, kerison. So now I can start to see the anatomy. I can see the OCR on that side, the optical carotid recess. I'm just going to remove this septation a little more. I want to see the optic before I aggressively remove these septations because I need to make sure this is not an Onodi cell, which is just a ethmoidal, a well-pneumatized sphenoid that comes up to expose the optic. You can damage the optic if you're not careful.
In removing the septations, what is the precaution we have to take?
I'm sorry?
In removing the septation, smoothing the area.
What's the precaution you take when you remove the septation?
Ethmoid, just want to pituitary, you just want to make sure that they're not too close to a critical structure like the optic or the carotid, and make sure you can identify these structures before you start biting the septation. So really knowing where your critical structures are is, I would say, the most important part. Otherwise, a lot of times too, I like to drill the septations. I feel it's a little more controlled than biting a septation. Do we have the navigation? Do we want to show our landmarks? Navigation? Do you have the navigation? Navigation. Where's the probe? No? No probe? Okay. Let's see if this will reach. So this should confirm that this is an optic here. It's very large, so may not. Can you blow that up bigger?
Navigation screen?
Can you make the axial larger? Can you zoom in?
Axial one.
The axial?
Axial.
But if you can just zoom in on all of them, yeah, bigger. It's not showing me well where I am here. There we go. Yeah. Okay. So now you can see my little dot. So it's showing me right on the optic here. So a bone window is nice. I probably use a bone window more than anything. And this is showing the other optic drill. So having a good bone window for this comparison is good. Let me just make sure. I think this is getting... Can we move this somewhere? It's getting... he's stepping
irrigation,
on.
section deep.
Because you have it under. They have the
suction
suction under your feet. Yeah. Let me move it behind you so it's not in your way. There we go. Okay. So there are a lot of little details like this setup in the OR that are very important working with two surgeons. And so it's not just how you as a surgeon can operate, but how is your whole team ready to do this kind of surgery? Suction's not working.
The whole in the side?
Suction's not working, yeah.
Tape down. The whole in
Can you... It's better now. Yeah, I think it's getting kinked or something. Okay. Okay. All right. So you can see here how we see an optic and a carotid. Stay more medial. More medial. Yeah. Over this way.
Okay,
Yeah.
okay.
So we don't want to center our endoscope view. We always want to keep it off to the side. Drill's not working.
About the burr, is it a diamond or a cutting? What is your advice?
So I like to use a diamond. There's actually a coarse diamond, which
coarse
is
diamond,
best.
yes.
Now this is a cutting burr, which I think is a little bit less safe. I like to use a coarse diamond.
Yes.
And we'll want the endoscope at like the 10 o'clock position so that my instruments are always off to the side so they're not fighting for the same position. Yeah, this drill will be a little bit aggressive, but that's okay for demonstration. But I would not use a cutting burr like this in a case.
Yes.
Suction's dead again. It's not continuing to work. It keeps dying. It's not working. It's not working.
ನೀನು 2 ಸೆಕ್ಷನ್ ಕಟ್ಟಿದ್ದೀರಿ ಅಂದ್ರೆ 2 ಮಾಡು.
This is very common, even in a case that your suction will stop working. I always have 2 suctions in any surgery, and sometimes maybe even a third as a backup, because this work it's critical to have good functioning suction to be able to do these surgeries. Now other things about the ergonomics, this table is really very much too high.
You want this view?
More to the right. Stay more to the right. Yeah. The table is too high for even Dr. Felix and I, so he's a perfect ENT for me to work with. He's the right height for me. You have to have an ENT who's a little taller than you are. You clear your scope? You flush.
Both the ENT surgeon as well as the neurosurgeon very tall.
Yes. So here we see one carotid, there we see the other carotid. You can see how they're very close together in this cadaver.
Yes.
And remember, the carotid artery is not very well pneumatized. It's not very well pneumatized, and the carotids are very close together in this case. So I have to be very careful not to damage them. I like to thin and remove the bone overlying the sella, especially if it's normal like this, by using a drill, because that controls the osteotomy that I'm using. You can see how this septation is going close to the carotid artery. And it's going to be critical that I have a very close, narrow view to be able to do this safely. So remember, the carotid has a C shape. It comes from medial to lateral to more medial. And the same thing on the other side, from medial to lateral to more medial. Very, very thick frozen bone. And the irrigation is critical also because it allows me to blue line and tell when I'm through the bone. Otherwise, I can't really tell if I'm through bone or not. Come in a little closer. A little closer. Yeah. So now I can start to really see when I'm getting through the bone. Stay just a little more medial. Yep. Mm-hmm. This septation here is, so as I'm working in here, I start to feel like I'm blocked out. So this septation is really blocking me, so I come back a little bit and I drill superficially. So your superficial removal and exposure, which Dr. Felix has done a beautiful job of, sometimes only when you get in and you start moving can you tell if there's other bone that's in your way. This is just a big septation in the lateral recess here. But here I can thin that down, and now when I come back in, I have more freedom of movement. Come in again, come closer. So now I have more freedom of movement. I can more carefully drill next to that carotid. The bone is not blocking me. And you'll notice how the scope is constantly moving to give me sort of the view that I need. It's following my movements. You really can't work with a scope in a fixed position. It won't work. All right.
I think you are using 0 degree.
Ethmo-pituitary. Pituitary. So again, stripping all the mucosa all the way up to the planum. Drill. Drill, please. So you see the septation, see how it's going right to the carotid artery there? Again, very, very thick bone. Poorly pneumatized, but that's okay. Now we're just starting to see the face of the sella here.
Yeah.
So now I can drill close to this other carotid, drill out the C shape of the carotid, and then follow it across to the other side. I'm always trying to drill parallel to the carotid artery itself. So let me see the kerison now.
Here it is very well pneumatized, retrocellular pneumatization of the
So let me
sphenoid
see
sinus.
now whether or not this
Yes.
bone is thin enough.
Yes.
I see a little bit of blue around the edge, so I think it may be 2. Always the kerison 2. We don't need that one. It's a kerison 2, yeah. Kerison 2 is a little flatter, and I'm using it like a dissector, which is why it's so important.
Yeah, great.
So I'm dissecting the bone. I'm not biting the bone. I'm dissecting, and where I've thinned it, I can then peel it free.
Yeah.
Pituitary, ethmoid. Pituitary. Pituitary, yep. So now you might say, well, this is enough exposure, but it's really not enough exposure. So I'm going to only expose the carotid on one side and show you how limited that makes me. So our flap is on the other side. Stay more medial. Our flap is on the other side, so I'm going to expose this left carotid artery. Clean, please. Maybe out just a little further, but a little more to the medial. Yeah, just like that, right there. Yeah.
That is paracellular carotid.
So remember that paracellular carotid protuberance is the most superficial
Yes.
and the most medial part of the carotid.
Wash. Devan, wash you. Devan, wash. Come here and wash.
He needs irrigation. He constantly needs irrigation. Yep. Yeah.
You come this side. Just keep irrigating, okay?
So I'm struggling to move here a little bit, so I'm going to come out a little bit, and I can see there's some more of the sphenoid here that I can expose.
Endoscope. One irrigation to me also. I need.
Can you flush, please?
No, it's stop now, Rambo.
Flush.
But stopness, very stopness.
Do you have another suction tip? In the meantime, yeah. So if there's bone that's blocking me, so if I can't move inside the sphenoid, I need to come out and see what's blocking me. So there's just a little bit of this bone at the entrance of the sphenoid that's blocking my access. Okay, come on in again. So now I can move more freely. And again, the drill, a lot of these drills have an extended tip so that I have a thinner, lower profile tip. Just stay more medial. Yeah. So now I'm going to follow the curve of the carotid, coming from medial to lateral. And I'm not going to even drill over that protuberance because the bone over that should be thin enough, I think. Stay back just a little bit, further back, yeah. So I'm seeing if it moves here, it's a little bit thick up top. So I'm just going to thin the bone up here. Now I'll take the kerison, see if I can peel this bone away. Kerison 2.
Devanand, if you are focusing the external camera from outside, we can see
So
the
still
hands of
too
the
thick,
surgeons.
so I'm going to drill some more.
Both
Very
the
thick
surgeons.
bone here.
External camera is showing only the faces.
Follow up. Yeah.
Yes. Thank you.
Kerison again. We'll try it again. See if we're thin enough. Come in here. Stay medial. Come. Yeah. Thank you. Come in. Yeah. I'll take a kerosene now. So see whether or not the bone is thin enough now over the carotid. Stay back just a little. Yeah. I just want to see the carotid. Yeah, there we go. You're perfect, yes. So I want to see the carotid as I expose it so I don't accidentally, flip the bone into it or something like that. So now you can see the carotid is completely exposed.
Yes.
Now for a complete cellular exposure, I do need to expose a little bit of the superior inner cavernous sinus. And normally I would drill that out. So this is kind of usually the cellular exposure, I want to see more of the carotid on both sides. So I want to see a little bit of the medial cavernous sinus here. But I have not exposed the cavernous on both sides. You have a smaller suction now. Smaller slotted section. Let me see what we have here. Let me see, can I see? Okay, that's probably best. All right, that retractable blade. So this is a nice little retractable blade that Storrs makes. Too small maybe, huh? Too narrow. So I like the suction to have a little teardrop on it because that allows me the ability to come on and off the suction in sort of a graded fashion. I use that for microscopic cases and, of course, endonasal cases. So here I'm going to make a little opening in the center.
It is a cella area, no?
And then I'll take a scissor left.
That is superior intercavernous sinus.
This is unfortunately not a sharp knife.
Yes.
11 blade long
Scissor,
handle.
the scissor to the left.
I take a sickle knife from this.
This is
Sandosh
left.
Surgical says sickle knife, sickle knife.
No.
One sickle
Scissor,
knife.
Scissor left, please. I think he was using it to make the cut. Here we go. Always a little more to the right. Yep. Mm-hmm. Come in. So now I'm going to try to use this scissor to get into this opening. Again, not so close. Back a little, yeah. So I'm going to make a little cut, not a sharp scissor, unfortunately.
Yes.
So I'm going to make an opening. Yeah, this is not going to work.
Sickle knife.
No. How about the straight scissor?
New sickle.
Do you have a straight scissor? Yeah. So if the scissor's too long, like that one was not the one we would usually use, it's too long, it actually bends as you cut, which is not what you want. Stay medial, medial. Yeah, there we go. For me, you have a pituitary.
Yes.
And then do you have a little dissector or a caudal? Okay, so now as you see, I can dissect here. We can see that now there's a layer of dura.
Yes.
And then there's a fibrous capsule over the pituitary, and then you can have a pseudocapsule over a tumor itself. So here's the fibrous capsule of the pituitary, and there's the gland itself. Now, I can't get into the cavernous sinus on this side because there's bone over the carotid. I can't get there. On this side, though, because we've removed the bone, I can get into the cavernous sinus, and I can even work here in the cavernous sinus. So you can see here, there's the cavernous carotid artery. You can see the medial wall of the cavernous sinus.
Yes.
So here's the sella itself, here's the gland, and here's the medial wall right there, and here's the carotid artery. So all of that I can access because I've removed this bone. On this side, I can't get to it. I can't see it, I can't get to it because the bone is still over the carotid. So that bone removal is really critical, absolutely critical. Let me see that big suction again. And then the drill. So now we're going to do a little more supracellular exposure. So I hope that convinces people that the bone removal is really important. And I'm just going to remove a little more on this side, and then we'll do the planum.
Section therapy.
Now the olfactory mucosa here has been preserved. We're just pushing it upwards towards the skull base, deflecting it upwards. So I'm going to try to do this a little faster on this side. Now when I do a planum, I always do an osteotomy medial to the optic.
Yeah.
Coming up above the optic canal, coming closer here, come in. Above the optic canal here. Come down here. Yeah, there we go. I'm sorry?
Lateral tubercular strut. How do you identify the lateral tubercular strut?
I'm sorry, one at a time.
How do you identify the lateral tubercular strut? The MOCR.
How do I know where the medial OCR?
Yeah.
Well, so I see the carotid. The carotid is my ultimate landmark for it. Remember now, the optic itself does not come into the canal. The optic nerve does not come into the canal. You have to come in lower.
So,
here. Yep. And pull back a little. Pull back a little. There we go.
Paul
Come
sir,
in,
can you show that?
right there. That gives me a
Hello.
view. Yeah.
Can you show that cisternal and preforaminal segments, canalicular segments?
I'm sorry. What?
Optic now.
What was that?
Cisternal segment, because it is not the optic asthma, no? Cisternal
We
segment
will
and
see it eventually. Follow me
preforaminal.
up here. Up. Come back up.
Canalicular segments.
The cisternal segment?
Yes.
We can't see it right now, obviously. So the cisternal segment will be right behind the medial OCR, behind the medial
Yes, sir.
aspect of the optic.
Yes, sir.
It's not, the optic actually isn't in contact with the dura
Yes,
until you
yes.
get much more lateral.
So yellow here is
Come in.
connected to canalicular segment, no?
Little irrigation. So I want to make sure we keep it irrigated so I can tell when I'm coming through
Yes, sir.
the bone. And then right here I can drill out over the optic canal, but I usually would do that separately. So I make this osteotomy immediately medial to the carotid.
Correct,
So if I want to do this over the other side, I really need to know where that, stay more medial, please. Medial, yeah. I want to see where that carotid is, so I know at all times exactly where the carotid is, so I can visualize where that strut is. So I tell where the strut is by exposing the carotid. Pull back just a little. Yeah. So I'm going to make another osteotomy again. And if you're having trouble seeing the anterior skull base, I can either reduce the septations or we can switch to an angled endoscope. Come in closer here now. But stay medial, medial. Yeah. And drop down just a little, pull back just a little bit. There we go, yeah.
That's an entirely different way actually we work because...
What's that?
It's an entirely different way which every team knows.
Well, so I think one of the critical things is for me to have freedom of movement.
I understand.
Yeah.
The view should be off to the side, yeah. And there's just sometimes depending on the angle of the planum, this can be very difficult. You have to sort of just get the view out of the side, and because this is a very flat skull base in this cadaver, an angled endoscope might help, but I think we're okay. We'll manage here. Come in closer. Come in. There we go. And you see it requires constant movement to have the right view. So I think we might need an angled endoscope, a 45, to do this planum, because it's just out of our view. Or we'll end up fighting for the same position. So let's switch, let me finish this side again, make sure it's completely through. Come over this way. Very thick bone. Pull back just a little bit. Back. Yeah. I need to see right here. Yeah. Okay, so now we'll switch to a 45 scope to see the planum. Hopefully this is an offset scope. What that means is that the angle of the scope will face the light cord, because the light cord needs to face up when we're looking up, which is not a standard sinus endoscope. So for skull base, you need what's called an offset. Is that not what we have?
No.
Yeah, so we do not have the right scope for this. No, it's not an offset scope. See how the light cord is pointing down? That's where my hands would be. So this is a traditional sinus scope that we have here. For skull-based surgery, ideally you want to have an offset scope so that that light cord is not in the way. Now we will manage here, but it's not where we want the light cord to be. Come in a little closer. Yeah. I don't know if that makes sense or not, but you can see how the light cord is pointing down in the same space as my hands would be in. So you have to order a special endoscope to work in skull base to have an offset. Coming closer. So here I'm right at the anterior planum. I think we're mostly through. I can test to see the bone moves, so I know I'm through enough. So I'll take a caudal now. Caudal dissector, please. Caudal, please. The caudal, please. And then rather than using a kerrison will be, let me see a kerrison for a moment just to show you. Kerrison. The kerrison will be perpendicular to the skull base, so it'll injure the skull base. Caudal back. So instead I like to work from anterior to posterior. Now here I've gotten through the dura, unfortunately, I've drilled through. But I like to dissect from anterior to posterior. Pituitary.
Now you are removing the planum.
I think it's safer now to peel the bone off of the planum.
Yes. Yeah.
This then allows me to see that planum dura much better. There we go. So now I'll switch back to a 0-degree scope now that we have the planum exposed. We'll switch back to 0. And I'm going to expose the optic canal so that we can really have a wide exposure at the planum. So I'm going to remove the bone over the optic just to show you exactly how wide we can get by doing that maneuver. So now to remove the medial OCR, we have our carotid exposed. I have to just thin the bone over the optic. Stay just a tiny bit more medial. Yep. Not closer, just, yeah, that's perfect. Beautiful. And this is the first time we've ever worked together, but Vinod is doing an absolutely beautiful job here of giving me basically perfect views, which is not easy to do. And he's working over his shoulder, so all of the ergonomics are wrong. Everything's working not in his favor, but he's making it look easy. Kerrison. So here I've done a little osteotomy over the optic. Maybe adjust the focus a little. Stay farther back, but adjust the focus.
Hold it. Yeah. 1 minute, little bit of focus.
Yeah, thank you. And then I can sometimes peel it this way, or if I need to, I can dissect in this direction with a dissector. Adjust focus. Yeah.
1 minute, scope is steady.
Yep. So this is just a little bit of bone. You have to be very careful peeling that bone off. Clean. So now above the optic.
Plane goes here, normal goes.
Felix.
Goes.
Felix,
Just the regular jaws here. Yep.
Felix, can you ask that box, PAP box, to bring it down because it's on the place you are operating?
Come in.
The PAP down.
Can you remove the PAP? Audiovisual team, remove the PAP, please.
PAP down at least.
So above the optic, I want to turn my kerrison up away from the optic, push the skull base back, and then come and show me the tip of my kerrison. Then I can just bite a little bit of the bone here, or I can drill it, and I'll take a pituitary now. And I can fracture this up away from the optic there.
Yes,
Same thing on the other
great.
side. Drill, please. Drill. So here I want to expose the carotid a little more. It's not fully exposed.
Yes.
And as well as the optic. Just a little bit. Come back. Just a little. Yeah, perfect. Drop down just a hair below me. Okay. So we're sort of trading which instrument's on top here a little bit. You can't tell that, but we're sort of switching around because this upper right corner is always a challenge because we're all in the same space. So here I'm just going to remove the bone over the optic, a little more over the carotid so that I can peel off the medial OCR. You can see it's critical to be able to visualize to do this safely. All right, let me see the kerison now, see if it'll come off of the medial OCR. So there's our medial carotid. This is medial OCR right here, is this bone as well as that right above it. And I'm not biting it. You see, I'm dissecting it and peeling it away with the kerison where I've done my osteotomies. So here's a little more medial OCR right here. I'm not going to bite it. I'm just going to fracture it off. And above the optic, I can push the dura away, and I can bite the bone above it. You see I'm above and below the optic, pituitary. A little bit of thick bone here coming onto the optic strut. Remember, the lateral OCR is the optic strut.
Optic strut, yes.
So, and above the optic is the anterior clinoid.
Anterior
All right, so
yes.
now I have a very wide exposure. Let me see that smaller suction again. And then a 45 scissor. Suction.
Is there another 0-degree scope?
The 45 scissor, the rotatable. Okay. So I'll often open horizontally across the sella like this, and then open horizontally just above the superior intercavernous sinus.
Yes.
Come more medial, please. And then it allows me then to coagulate and cut
You're cutting
through the superior intercavernous sinus.
Yes.
Let me see the straight scissor. So a bipolar here, I can coagulate and cut
Yeah.
through the diaphragma,
Yes.
and that will take me back directly onto the pituitary stalk. Now, in a cadaver, you can see the chiasm can sometimes drift down inferiorly, and so this is actually our chiasm, or carotid. Come in close here. Come in.
Okay.
So that's our chiasm, and it's just sinking down because this is a cadaver. And there we see our pituitary. Let's see if we can find the stalk. Come in, please. There we see the stalk.
Stalk, yes. We are
So there's the pituitary stalk. So this is chiasm here.
Yeah.
Pull back just a hair. 45 scissor.
So this is
The
infrachiasmatic
rotatable scissor,
dissection,
please.
no?
Rotatable scissor.
Paul?
Yes.
This is infrachiasmatic dissection, no?
I'm sorry?
This is below the chiasma, in front
Yes,
of the
yes,
infundibulum.
very
Yes,
much so.
stalk, yes.
And it wouldn't normally be this low, so you see, pull back just a little bit, come back, just come back. This is prechiasmatic sulcus.
Yes,
The chiasm should be up here. Because it's a cadaver, it has sort of sunken down. Sometimes tumors can change that relationship too. The dissector now. But if I open out along the optic, because I've exposed the optic, maybe adjust the focus a little. Adjust the focus a little. There we go. So here we can see our pituitary stalk.
Yes, yes.
There's our, actually a little bit of posterior clinoid. Here's the optic coming out into the canal. Follow me out, out. There we go. And then just below it is going to be the carotid. Come in a little more medial, yeah. There's our carotid right here. This is all carotid artery, and we get a hint of the ophthalmic. Pull back just a tiny, there we go. So here's our carotid. You can see a little bit of the optic strut is still blocking me, but the whole optic nerve has been exposed, and I can follow it all the way out into the canal. And I'm sort of pushing the chiasm up because it's sinking down in this cadaver. Normally it wouldn't be so much of an issue. If I follow back through the stalk, come to, there we go, yeah. There's our stalk.
Yes.
And we can follow back through this. Here's where we would come into the third ventricle. It's actually frozen. Third ventricle is frozen. There I'm coming into the third ventricle, but it's full of ice.
Yes.
So the CSF has turned to ice. And that, I just came through the floor of the third ventricle like we would for a third ventriculostomy, and there's ice in the third ventricle. I can put in the navigation and show that to you. Maybe. Pull back, it won't reach, not long enough, oh well. All right, a dissector again, or scissor, how about the straight scissor? Straight scissor. So we can go now into the interhemispheric fissure,
Yeah.
and I can split the interhemispheric fissure. Now, I don't usually like doing an ACOM aneurysm because I think a lot of times I don't have good proximal control, but you can clearly go into the interhemispheric fissure here,
Interhemispheric fissure.
and there we can see our ACOM complex. I can open up more anteriorly. Stay back just a hair.
Yeah.
There we see our ACOM,
Yeah.
all very frozen. You can see the ACOM itself. You can see the A1 coming up over the top. You can see it going into the interhemispheric fissure. Everything's very frozen here. But that's our ACOM complex there. You see it? There's the actual ACOM.
Which is gyre-erector.
There's the A1 from that side. A1 from the other side. There's the ACOM. And that's the kind of beautiful view that we get. Any questions about that exposure? You can see the bony exposure is the critical thing, dissector.
Paul, sir?
The
Can you
bony
show-
exposure is the critical thing for us to be able to see all of these structures.
Can you show the anterior clinoid process, middle clinoid, and posterior clinoid process?
The anterior clinoid process is going to be, follow my instrument here, is going to be just above the optic here. So this is anterior clinoid up here,
Okay.
above the optic on the
Middle,
other side.
middle.
Yeah, here's anterior clinoid process here. You can remove, Kerrison, only about 20% of the anterior clinoid process. Usually I would drill into that, and we can remove about 20% of it. You can't remove much of the anterior clinoid process
Yes.
through an endonasal approach, at least not safely, in my opinion. I can use that, though, to decompress the optic even more so. I can remove a little of the optic strut, especially right here. You need either a very small drill bit or very careful kerrison, because if you're too aggressive with your kerrison here, you can actually run into the ophthalmic artery.
Yeah.
So biting here can be very unsafe. You want to drill this and thin it and then just fracture it if you can, and if it's too thick, you need a very small drill to drill it out, which we don't have here. I would not normally kerrison this because I worry about running into the ophthalmic artery. You have a pituitary. And then the dissector. I want to be very careful with the optic there.
Oh.
Yeah, if you can hand me this part. Thank you. Come on in, up above. We can see the carotid right here, and this is the ophthalmic artery right there. You see the ophthalmic artery there?
Yeah, great.
So very close by.
The
Come a little
relationship,
more
it is
lateral.
inframedial,
Just a little
no?
bit. I'm sorry?
It is ophthalmic artery is inframedial to the optic.
No, it's coming off lateral,
Yeah, yeah, lateral.
but we're just that far lateral. Here's the
Yeah.
carotid, and here's the ophthalmic artery,
Yeah, yeah.
right here.
Then where is the middle clinoid?
I'm sorry, middle clinoid?
Already gone.
There isn't really one, it would have been gone, so the middle clinoid would be right here.
Yes.
The middle or medial clinoid is here when it exists. The medial OCR is just above that. The anterior clinoid is above the optic. The lateral strut is the OCR.
So paraclinoidal carotid.
And then this is, again, the chiasm is really sagging down in an abnormal position here. But this is the kind of view that we would get. We can't, you can get a glimpse of a, can you stabilize it? Of a superior apophyseal artery there, perhaps. They're not well visualized here. The arachnoid's not very nice, but you can see here, this is the kind of view we can get. Even going back onto the optic tract, this is going to be the posterior clinoid here. That's posterior clinoid next to the carotid, right here, posterior clinoid. Okay, so we can see all of the clinoids from this exposure. You just can't get to all of them.
So where to look for the distal ring and the proximal ring?
Yeah, so to cut the distal and the proximal rings, we would have to open the cavernous sinus. So opening the cavernous sinus is something we can do now, or I can show tomorrow. We have coronal plane dissection tomorrow. I was going to save the cavernous, but I can do cavernous now if you would like.
You can do it now.
Yeah, come in a little more medial.
Well, I think now that it's actually frozen, we can wait one more. So it's frozen now. We'll wait one more. The nerves will be more clearer tomorrow.
Up to you. I'm happy
The
to
cadaver
do
is
either.
frozen now. We
Yeah,
have
yeah, yeah.
switched. So
I'm
it's
happy
better to do
either way.
tomorrow.
Okay. Yeah, no problem. Perfect, yeah. So I'll show the dural rings tomorrow, I can maybe just show you real quickly where they are, but I'll show you them much better tomorrow when we open the cavernous sinus.
Yes.
Because they come from the anterior clinoid, and laterally they are on both sides of the anterior clinoid. So if this is anterior clinoid above, they're coming from each side, and then they come to, this is distal dural ring, and then the proximal dural ring will come basically through the cavernous sinus,
Yes.
and they meet medially at the diaphragma. So here's carotid, the proximal ring will come around, the distal ring becomes the diaphragma, and they meet on this medial part of the carotid artery.
Yes. Yes.
So they come together at the diaphragma, and I'll show you that better once we dissect
Yes.
the medial cavernous sinus tomorrow.
Yes.
Okay?
Paul, sir?
Oh, let me
Sir,
show one
two,
more.
Two questions from the neurosurgeons.
Yeah,
One
yeah,
is
absolutely.
Paracellular
the
ligaments. Please.
One second. Go ahead and ask the questions, but I'm just going to show the flap going up into the position we would put, which would be along the lateral nasal wall and then up onto the defect. What are the questions?
One question is regarding paracellular ligaments.
Paracellular what, I'm sorry?
Ligaments.
Yeah.
And the second question is regarding pituitary transposition.
Higher up. So,
Transposition.
so the cavernous ligaments, the paracellular ligaments, I can only show you when we do a transcavernous. So I can show you tomorrow the ligaments. The carotidoclinoidal ligament is the proximal ring, and this is broken, isn't it? It's broken.
It's not, okay.
The pituitary transposition, so here is just showing how the flap would go up and cover all of this. If it did have a hole like this, you could take it onto the floor, or we could put a piece of fascia lata behind it. I'm going to put this down below for now. Let me see that dissector back. And to do a pituitary transposition, you have to expose, pull back just a little bit here, yeah. So to do a transposition, I would have to expose the upper paraclival carotid artery. We would have to open the cavernous sinus to get to the dorsum. And so here is basically the maneuver, but pull back. I would have to drill out the entire upper clivus.
Upper clivus, yes.
I would have to expose the paraclival carotid artery, and then I can open the cavernous sinus to lift up and do a pituitary transposition. Again, that requires a clivectomy, and we can maybe try to show the cavernous sinus dissection with the paracellular ligaments and a pituitary transposition when we do coronal plane tomorrow. I think those are good goals to do. Okay?
Great.
All right, excellent. Thank you.
Excellent.
I think a scope, I think, is not so.
Paul, sir?
Do we have a newer scope? The focus is not so fine.
Nice
Oh,
job.
yeah, zero, yeah. Yeah, thank you, sir.
Thank you.
Felix? Felix?
Yeah.
It's a standing ovation from the auditorium, please. Can you see? Yeah, please.
Thank you.
Thank you for Paul. Yeah. Great, sir. Thank you. Thanks a lot.
Thank you, sir.
We'll have to see
Paul,
if
sir,
we
and
can-
Vinod Felix. Okay.
see if we can get this lower.
Thank you.
Next, we will have the much awaited session for today. There's the cadaver demonstration of coronal plane by Dr. Paul Gardner. Over to you, sir.
Just before we start the coronal plane, I would just do the initial exposure part. And then maybe I'll just take like less than 25 minutes and hand it over to Dr. Paul. So the basic thing is that once you, for the sagittal plane, you are staying between the plane of the two carotids. So this actually is a cribriform, just to orient it, is the cribriform plate. That's the suturing done by Dr. Udo. And these are the carotid arteries. The clinoidal carotid on right side, clinoid on left side is the optic nerve, left, optic nerve right. That's the sella. What is this? There is a turbinate on the other side which is cut down. Okay. It's a middle turbinate cut down. I'll just take this off from here, scissors. Blackisly. Pituitary. The pituitary when I asked for the Blackisly. Okay. No, I need to zoom it. I need to zoom, please. Blick asleep. Just take the flap out. So right side middle terminate. Okay. Now the elevator. Is the suction on? Can you give a saline wash? Okay. One more wash. Good wash. All this bone dust should come off. And get another 2 big sections ready because a lot of bone dust will be collected and get blocked. Okay. 2 more same sections. Okay. Is blocked now. Another section. Okay. Now the elevator. So basically, to work lateral to the carotid, you need to remove all the structures which are obstructing here, and that will be the pterygoid plates, just like what you saw in the 3D lecture now. And to get there, to get to the pterygoid plates, I need to open the proximal corridor, which is the maxillary sinus. I can just do that by doing a big middle meter androstomy. That's the maxillary sinus. I can do a very big MMA and do most of the limited transpterygoid work. But however, if I need further more exposure, I can do a medial maxillectomy. And to make things better or for a bigger exposure, I can go for the modified Denger's approach. Scissors. So the myos. Can you get this? Okay, there's some smoke running in this field. What is that? Is this a smoke or the ice getting vaporized? It's the ice melting down. Okay. So we can do the large medial maxillectomy just by taking the scissors like that, dropping it into the maxillary sinus and making a cut. So you can do it like that and get a limited medial maxillectomy. Or I can also take the knife, 11 knife. For most of the sinonasal work, I do this sort of incision. I just make an incision here. A horizontal incision above the inferior terminate, bring it till this level, and here I make a vertical connection like that. So that if I need to widen the widen the medial maxillary, I can just go on, remove this piriform aperture and extend it to the Denger's in the single incision. That is what I generally do for the pterygopoelin fossa tumors. And I start by preserving the inferior turbinate, the nasolacrimal duct, and depending on the demand, I just keep on sacrificing one by one. Knife again. Okay, there we go. So I can bring down the inferior turbinate like that, push it down and preserve it here. And later on after the surgery, I can put it back. And if I need more exposure, I can actually come here, knife, and remove the piriform aperture and go to the maxillary sinus by preserving the piriform aperture. Can you connect the coablation? We'll show them the coablation also. course, I don't need a coablation for the cadaver, but then, and many of the neurosurgical crowd may not have seen the coablation, so I'll just show you the coablation also. Why it goes? Okay. Elevator. See, when you remove this pyriform aperture rim, you can have a cosmetic deformity if you remove a lot of that bone there. But what you can also do is that you can actually just keep the rim there and open the maxillary sinus lateral to that, the anterior wall of maxillary sinus. Coablation, please. Do you have a Langenbach's? So that is your anterior wall of maxillary sinus. And there's a zygoma there, and this is the infraorbital nerve coming down, coming up there. So I can do this exposure. That's the infraorbital nerve. Can I get the ball probe? Can you retract it like that? Hold it, no, hold this elevator like this. Take a thumb away, okay. You don't have a ball probe, huh? Take it from surgicals. Ball probe, please. So actually this divides into the two branches here. That's the infraorbital nerve dividing into the anterosuperior alveolar nerve and the middle superior alveolar nerve. You can see the two branches very clearly there. Take it off now. You know, I can actually retract. I can actually now drill this bone here, open a window there into the maxillary sinus, keep this pyriform aperture rim intact so that I can prevent the cosmetic deformity. So I can do a very big middle metal androstomy, I can do a medial maxillectomy, just preserve this rim of bone, come here, drill it, make a hole there, and work into the through the maxillary sinus, to the posterior wall of maxillary sinus, to the pterygopylean fossa, and then to the pterygoid base. So I'll now remove this inferior turbinate because this being a cadaver, I would like to have a better room. And of course, if I do that, I'm sure Professor Gardner can show much more structures with much more comfort. So that's the inferior turbinate being peeled off. Can you get a scissors, big Mayo scissors? Mayos. So this here is the congal crest of the maxilla, where the inferior turbinate attached to. Pituitary? But mind you, once you remove the inferior turbinate, there will be a lot of crusting, and that actually can cause a lot of nasal morbidity. So it's always better that you try to preserve the inferior turbinate. Removing the middle turbinate may not cause much crusting, but removing the inferior turbinate causes a lot of crusting and the posterior morbidity. Chisel hammer. Or, what do you call that? Bone punch. Nibbler. Can I get a nibbler from there? Bone nibbler. Section. For just being a quick, I will just take a chisel hammer or a bone nibbler and take this bone off. Can you hold it like that? Okay, you have a chisel, big chisel. Okay, there we go. You hold it in your one hand and then hit, or else you don't have the control. Yeah. Good. There we go. Hit. Okay. Now head strip. Can you bring it up? You got the bone nibbler? Yeah. I'm sorry that the cadaver head just slipped down. I had to fix it again. Will it slip again if I hold it like that? No. Done? Okay, so I'm not going to hit anymore. Can you just hold the head for 1 second? Just hold the head. Take it off. There we go. Now the kerosene sponge. So that's the nasolacrimal duct. See, you saw what I did. Just holding it like that and avulsing it from the duct. So that is your nasolacrimal duct. You can preserve the duct if you need a limited exposure, and if you need a bigger exposure, you can cut it. The pituitary forceps. And remove this bone around the duct. Okay, it's with me. Yeah, okay, there we go. Flex forceps, sorry. There we go. So that the palatine bone. Now the scissors, my scissors will cut the duct. Scissors. There are several ways you can cut it. Some people advise to go till the bone and make a cut there. But surgeons like Castelnuovo, Paulo Castelnuovo always says just leave a stump there, don't cut it till at the level of bone. So there are different concepts and different schools of thoughts. You can follow which actually works better in your hands. And you can cut it actually sharp on an oblique manner. There we go. Okay. Section now. So that's the posterior of maxillary sinus. Now you got the maxillary sinus opened up completely in the medial aspect and the anterior aspect. So that gives a very good window to the structures lateral to the carotid artery, lateral to the paraclival or the cavernous carotid artery. And you can already see the color of the greater palatine artery, maxillary artery, the sphenopalatine artery, everything through the maxillary sinus. Blackesley? Yeah. Clean. 45 Blackesley. So that is your infraorbital nerve. There's an infraorbital nerve running in the roof of the maxillary sinus or the floor of the orbit. That's a very good landmark to find the V2 because you can trace it back to the V2. No. Elevator. Elevator, the caudal elevator. Now you can leave the head. I think it's more or less stable. That's again the palatine bone, the vertical plate of palatine bone. This is your orbital process of palatine bone there. There is your sphenopalatine artery. That's a crest, that's a ethmoid crest, which actually is a landmark for the artery. Sometimes there can be multiple foramens for that. You can have like 2 or 3 foramens at times. So keep that in mind. And this actually is your spinal process of palatine bone there. That's a spinal process. This is the medial pterygoid plate, and this is a spinal process of palatine bone. There. This is the medial pterygoid plate. And that's a suture line which actually you saw in Dr. Jessica's talk. Can you get the kerosene sponge? I can just sponge that off and try to expose the greater palatine canal. Sometimes just comes off like that. Hold the head, please. I don't want to use. No. For lex forceps. Actually, another landmark which I think is a good landmark to differentiate the palatine bone and the medial pterygoid is the greater palatine artery. I don't know if Jessica and I am right in that. Okay, there we go. Yeah. That's it. Pituitary. Greater palatine artery. Do we have a blunt probe? Out in the blunt probe, this is a big one. That's normal blunt probe, which is in neurosurgery, the small one. Okay. Do we have one Keresens? Size 1 Keresens? I'm opening up the pterygopalatine fossa now. I can trace this greater palatine into the maxillary artery. And that's a takeoff of the sphenopalatine artery there from the maxillary here. Keresens now? One Keresens. It's broken. Another punch. We need another one Keresens because we need one Keresen from this set, okay? I'll try to remove the orbital process also and make the corridor a bit bigger. Lux forceps. Keresen sponge. The blunt rope. No. Okay. Okay, so to orient you again, this is the greater palatine artery. I can retract that and look at the lesser palatine there. It's a greater palatine, and this probably is a lesser palatine there. That's a lesser palatine. Can you see that now very clearly? It's the greater palatine artery, greater palatine nerve, and this is the lesser palatine. I can just elevate the structures and expose the pterygoid base. I can cut the artery first. Can I get the scissors? Myos. Just don't give the turbo, just myos always. Elevator. Cortals elevator. And that is your palatovaginal coming out there. That's a palatovaginal, and this actually is a sphenodorsal-palatine bone. Can I have the small micro scissors, please? Or I can just cut it like that. Yeah, it's gone. Okay. Now, this is a pterygoid base. Once I retract that, I can see the Vidian canal already. There's a Vidian canal there. It's a Vidian canal. Can I get a small kerosene sponge? And I need a small cutting burr. I think, Paul, you would like to join now, or you? And this is your lateral pterygoid plate. I can work here and go to the foramen ovale also. I'll just sacrifice this artery. Can I get the scissors? Fine scissors, please. So this is intraorbital nerve. This is the infratemporal fossa. This is the pterygopalline fossa. This basically divides the area into the pterygopalline fossa medially and infratemporal fossa laterally. Can I get the elevator now? Caudal, always caudal. So that is the under surface of the pterygoid base. I can follow it to the greater wing and find the foramen ovale. I just need to get the subperiosteal plane, which I'm finding a bit difficult here. I don't know why. This is the wrong plane. Paul is ready? Yeah. Do you have coablation connected? Once I release it here, I can go to the ovale much more easily. Can I get a ball probe? I can already feel the ovale there. 1 minute, 1 minute, 1 minute, 1 minute. That is actually your V3. That's a V3 coming off. And now I got a correct plane. This is a plane which I need. That is ovale. Can you see the ovale there? That's a foramen ovale. Okay? There is a foramen ovale. Right. So, yeah, right. So, you need to more higher up? No. No, we'll just change it. Virendran, yeah, one, I'll just take this cable off. You come now.
Yeah, but don't tilt it. Tilt it back. Great. Perfect. Thank you. Yeah. Oh, we have a different section. Thank you.
Can we have the drill here? Drill. Electronics. In the burr, can you just show all the burrs? Or we have all these burrs. You can select whichever.
Wonderful. Oof. Okay. These are too small. So usually I would use a coarse diamond. These are all cutting burrs, which is not what we would use in the skull base, but we can make it work. I think this looks pretty good. One of these two is fine. So a coarse diamond burr that has a coarser cover to it is good. Here, we have these right here is good. Another, just one suction is okay. It's okay. So a coarse diamond is very nice because it gives us some precision, but it's more aggressive than just a regular diamond. Let me see a pituitary here.
It'll take some septum, I think it's blocking your ear, maybe.
Yeah, let me see. Let me get some of this other stuff cleared out. So so you did a Dankers in this case, yes?
Yeah, partial Dankers.
So a Dankers we don't usually do unless you need infratemporal fossa access or much more lateral middle fossa, but it will give us some really beautiful access, and it's really a beautiful approach that was done there to help us understand this and get to this anatomy. And understanding the trans-pterygoid approach is critical for access for anything in the coronal plane. Come in closer here, please. A little closer.
Wash.
Come in closer.
Can we take this off, that flap?
Take the flap out?
Yeah.
No. Well, we should pretend like we're actually doing surgery.
No, but okay, right, sorry.
So the reason I want to leave the flap is I want to show also some of the things that we have to deal with the flap. Come in closer here, let me see the flap. So this is what, middle turbinate residual there?
Must be.
Me have a through cut?
I don't know if they already took the flap
Through
off.
cut? A through cut? Through cut? Through cut? Yeah. Thank you. All right. So I think
I think flap already has been. That's a flap. That's a flap. Okay.
Come in a little closer, please. A little closer, please. Yep.
I just get it clean.
Yep. Mm-hmm.
ഇത് ഇവിടെ ഫിക്സ് ചെയ്യാൻ പറ്റുമോ എങ്ങനെയും ഇത് ഇവിടെ ഇങ്ങനെ വെക്കാൻ പറ്റുമോ ഇവിടെ അല്ല ഒന്ന്
You might be more comfortable if you drive with your right hand. I don't know if you do that ever or not.
You mean the scope with the right hand?
Yeah, you may be more comfortable. Yeah,
it's okay, but that's okay.
Yeah. Pituitary? Do you usually drive left-handed?
No, I'm right-handed.
Okay.
But I have the other instrument in the other hand. So
I see.
ഇവിടെ വേണം ഇവിടെ ഒട്ടില്ല അത് ഒട്ടിച്ച് വെക്കാൻ അല്ല ഒന്ന് ഒട്ടിക്കാൻ എന്തെങ്കിലും പറ്റും നോക്കൂ.
Okay, so let's take our flap, and a lot of times if we have a flap, our flap's gotten kind of beaten up here. If we're doing a trans-pterygoid approach, you can even put it up in the sphenoid, or show me the maxillary on this side. You can make a small maxillary antrostomy, and you can place it into the maxilla on this side. For now, we'll just place it up into the sphenoid because we have that extra space for it. So we seem to have pretty good access here. Through cut again. The suction's not really working. This one isn't very good. Stick with this one maybe for now. Yeah, that one's not very good. Through cut. So I'm just going to release a little bit, and a lot of times we do dissect off this mucosa off of the medial pterygoid plate. And I'm just going to expose the nasopharynx here because I think that'll help our understanding as well. I'm going to disconnect this little bit of posterior septum just to help us see the rostrum and the nasopharynx because there are some nice landmarks in between. Pituitary. Clean first. Okay. Clean. I'll try to get you a very nice clean view here of pituitary. The ice has thawed, so our iceberg that we had in the nasopharynx is gone.
No, we had a bit, it's a tumor or iceberg. We were speaking yesterday.
Cuddle. So one thing that I showed in the odontoid case was the maxillary crest. And if you see here, this is the maxillary crest, which is just the attachment of the septum to the hard palate. And if you want to get more inferior, you need to drill this down, because what you see is that this maxillary crest is the highest point, and it'll push my instrument up. If I drill this down, I can get much, much lower. So if you really want to get down to the odontoid, you have to drill out this maxillary crest. So here's the eustachian tube. We want to preserve that. This is the pterygoid wedge. Come up higher. Higher, higher, higher. See, show the pituitary. I want them to understand that. Yeah. So here's the pterygoid wedge. This pterygoid wedge will point...
The median is here.
Yes, yes, yes. I know. I understand. I'm trying to... The pterygoid wedge is the landmark for foramen lacerum. So if we drill this pterygoid wedge and go straight back, that will take us directly back to foramen lacerum. The vidian nerve goes lateral to foramen lacerum and goes over to the horizontal petrous carotid artery. I don't see our palatovaginal or palatosphenoidal artery well. There it is right there. You see right there?
It's
coming
cut,
through?
it is cut there. It's cut there.
Yeah. So this is that's the palatosphenoidal or palatovaginal, and this is pretty well pneumatized. So it was pointed out in the 3D lecture. Become more immediately here. When it's well pneumatized, you can actually see the vidian here in the floor of the sphenoid. So you can see sort of an indentation where the vidian is. So I'm going to drill medial to that, which will take me through the pterygoid wedge. So I'm going to drill through the pterygoid wedge straight back to foramen lacerum. And if you don't have good landmarks...
There is a discussion regarding following the vidian to the lacerum, but I always feel that it can be a bit risky if you just blindly follow the vidian. What do you feel? Like?
I think you'd have to realize that the vidian does not go directly to lacerum. Coming closer, please. Closer, closer. When we first described the vidian, we described it as a landmark for lacerum, but it technically is not. It is a landmark for the horizontal petrous carotid. It goes... Yeah. So staying medial to it, indeed, will take me to lacerum, and you can use it as a landmark, but you have to understand that you'll run directly into it. You'll run into foramen lacerum. So I'm going to drill out, this is basically base of pterygoid and medial pterygoid plate, and I'm going to drill out around the vidian just to try to leave it intact, try to not sacrifice it, and show you how as I go medial, come a little higher here now. Oh, sorry. That will take me down directly onto lacerum. Now, pituitary. Come close. Caudal. So if, in a case like this, which is often what we run into, it's not well pneumatized. I can't tell exactly where that paraclival carotid is. So I have two landmarks. One is my pterygoid wedge, which I was drilling. That'll take me straight to lacerum right here. It took me right to it, okay? This is still a little bit of mucosa, but that's right over lacerum. And then I can come at the floor of the sella, and I can walk along the floor of the sella until I see, come up a little higher, yep. I see where the carotid dips down. So there's my paraclival carotid running from here straight down to here. Pituitary, and it tends to be a very straight line. So if I know where that pterygoid wedge is and where my vidian is, I can follow it straight down. So again, between the paraclival at the floor of the sella, where the pterygoid wedge goes straight back, and I can drill between the two a straight line. And that will take me down directly onto the paraclival carotid. Can you flush the scope, please? Flush the scope, clean the scope, yep. So when I start drilling towards the carotid here, I need to really be...
Section sublock.
I need to make sure I have a very tight view, because if I don't have a good view, you can run right into the carotid and not even realize it. So it really becomes important, even though there's drilling, there's a lot of bone dust flying, irrigation and everything. It's okay. Come in closer. I really want to keep a very close and tight view here.
Irrigation. Give one irrigation to me also.
For him, yeah. Suction. Coming closer. Pituitary. Clogged. Section. Unclogged, please. So these little bone chips are always a bit problematic. We want to make sure and clear them all out here. Drill. So I've defined pretty well here where I think my foramen lacerum is. Come closer, please. And I'm drilling now between the floor of the cella where I found paraclival. It's the suction dying.
Do we have a Yonkers section?
This one doesn't work. This
Can I
doesn't
get
work yet.
one section, one Yonkers to me,
week,
please?
2 week, yep.
For
It's not
Yonkers,
that.
yeah.
I don't think we need another
I'll put
suction. This
another-
one,
No, it's okay.
it's not necessary. This one just keeps blocking.
Yeah,
So
yeah.
I think we don't have a lot of, if it's working well, it's okay. But I think it's just stopped working. It keeps getting clogged. Pituitary. Pituitary, please. Pituitary. So I can also see how there's a little bit of cancellous bone here too. You see that's clearly not cortical bone. So when it's not well pneumatized, one of the tricks is always just to drill down through the cancellous bone. And then once I get through the cancellous bone, I'll start to see cortical bone. So now I start to see cortical bone. Come in closer, please.
Is the lacerum already there? There? Yes, sir. Is it the carotid there already here?
I'm sorry.
Is it the carotid there here?
No, not yet. Not quite yet. Come in closer. A little more medial there, yeah. A little more, stay more medial, yep. Uh-huh. Come in. Now you're twisting the floor of the cella.
Okay.
Yeah, we have to, this is always the way it is, where you have to have a constant discussion about the position, because both of us can get, I can get disoriented, and we need to make sure that we agree on how where our view is straight or not. Please, no, it's too much, okay? Too much irrigation, dude. Because the suction just won't deal with it at all. So, as I'm drilling here, one of the problems with this drill, show me the drill more. You see how the drill, because it's a very thick shaft, so having a thin shaft on the drill helps, because there are extended tips that Medtronic makes.
No, we
Come
have the
in, come in
transnasal.
closer, please.
Do you need the transnasal too?
If you have it, yeah.
We have it. We have it.
Okay. Yeah, that's what I asked them for, but they only showed me these cutting burrs. So that will help, because the thicker the drill is proximally, the more you have to remove tissue proximally. Coming closer now again. I'm sorry? Okay, yeah, great, wonderful. Yeah, so this drill also has a little curve to it, which helps me work around some of the superficial bone, but there are many times where you do really have to.
You need to have the irrigation there?
Oh, beautiful. It irrigates for itself. It's just a smaller cutting burr is the issue, yeah, it's smaller, okay. Come and say a little more medial. There we go, yeah, beautiful. Just so I always see the.
Switch on the irrigation, please.
Flush the scope, yeah. Can you flush on the scope? Come in closer, please. Don't twist, though. Don't twist.
Okay.
Yeah.
Where is the cell? Yeah, got it. Yeah.
Yeah. There's floor of the cella. That's
Yeah,
what
got
I'm
it, got
using
it,
as
got
my
it.
horizon
Got
mark.
it. Yeah, yes.
So this is all just cancellous bone here, and I have some idea that it shouldn't come in a little closer here.
That's the carotid, right? There.
A little less irrigation, a little less, not so much. Go down to 14. 14, I think, is about right.
Is that the carotid already, right? That's one?
Right here, yeah.
Yeah.
There's a bit of paraclival carotid that you see right here. And you see this is all cancellous bone medial to it. But look how the vidian is running directly lateral to the carotid. So this drill helps me now work a little bit around this. Can you flush the scope? Can you flush down the scope?
Scope. Irrigation.
Irrigation, yeah. Yeah. Yeah, on the scope though. Yeah, there we go. Great. Okay, beautiful. Come on in. You can see how this really, and I really want to emphasize the teamwork that's necessary to do these cases properly. Coming closer here. And this carotid is actually kind of a bit of a tortuous course from the floor downward. Do you have a, let me see the caudal now. Actually, let me see a kerison first. So one thing I want to show you, kerison 2. Is that I don't like using a kerison as a right-handed person. This is a completely blind maneuver. And reaching down towards the carotid is very dangerous. This is that case I showed you where you can slip. Now you can potentially come upward, but what I prefer to do, and what I think is much safer, is to simply thin the bone and then you use a dissector from the top down to dissect it free. Come in closer, please. So I like a very close view for this so I can tell when I'm through. Come in closer. Closer, 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 closer. There we go. Caudal. And again, a diamond burr would be much better for this.
Sort of anomalous turn of the shift of the carotid medially on this side, left side.
I'm sorry?
The carotid bit anomalous on the left side because generally goes slightly more lateral.
I don't understand. I'm sorry.
Is the carotid bit more medially pushed on this side?
So the carotid is tortuous here.
Yes.
So normally this should come straight up to the periclival.
That's what.
Yeah, here you can see the periclival, but this is why you come along the floor. Come in here, show this. This is why you come along the floor to see where the periclival is. You can see that the paracellar cavernous carotid right here is more medial than the periclival carotid. Drill. So I'm going to drill out a little bit of the clivus here just to show you. Not well pneumatized, so we'll have to drill it all out. So again, I prefer a very large, like a 4 or even a 5 millimeter coarse diamond burr. I think it's a little safer and you can still be effective with a larger drill bit that way. Ethmoid or pituitary, a Blakesley if you have it.
Pituitary.
So now when I'm working here, I can place the flap even into the nasopharynx to keep it out of my way as I'm working in the clivus. Drill. I want to constantly keep the carotid clear in my view so I don't drill into it. It's very easy to get disoriented here. You can see though, once you find the periclival carotid artery, it's very reliable because it tends to be very vertical. Unless there's a tumor that displaces it, you can depend on it being very reliable. And also when this is not pneumatized like this, you can just drill through the cancellous bone. This would be maybe kind of like a pediatric case where it's not pneumatized. And so just drilling through the cancellous bone can be very helpful as a landmark until you get to the cortical bone.
Paul?
Yes.
Actually, here the posterior process is an important landmark, am I right?
I'm sorry?
Posterior process.
Posterior
Sorry,
clinoid
it's very hard to hear.
They're asking about the posterior clinoid process.
Ah, yeah, so that
is
will,
an important landmark, no?
It's an important, it's a landmark for carotid, that's what.
Yeah.
the posterior clinoid?
Is it?
Is it a landmark for carotid?
Because
No,
when you are dissecting that area,
The posterior clinoid for this is not a landmark, no.
Yeah.
Because the posterior clinoid is so far behind, is behind the pituitary, you really don't see it well. So it can be a landmark, certainly when you're doing a transcavernous approach or doing an open approach, but here it's not a really good landmark at all for the carotid, unfortunately. So here I'm just drilling out the cancellous bone. You can see how this takes me down to cortical bone.
I think you must show them the petrosal process clinoid bone also.
I will, yeah. That's a main reason I'm drilling this out, so we can try to show them
but
that.
here it is very well pneumatized. So when you are going nearby the foramen lacerum,
Wash.
So here we've made a clival recess essentially.
Yes.
And you see the issue with this drill is it will come right through the dura.
Want a diamond?
Do you have a diamond burr? I didn't see a
Yeah.
diamond over there.
Yes,
I didn't see a
there's
single
diamond,
diamond. I
there's a
only
diamond.
saw cutting burrs.
That's a diamond. We have a diamond. Transnasal? Transnasal diamond.
Oh yeah, this one. I'll stick with this for now. I think it'll be okay. It'll take too long with that. That's a really, really narrow diamond burr. It's a very, very small diamond. So I will show a posterior clinoid in a moment here.
Yeah.
And then I'll show so one thing you'll notice about foramen lacerum is that we can really go quite lateral here because lacerum tends to dive away from us a little bit. So once you see the paraclival carotid, you can really follow its contour. And then it's important as you come below foramen lacerum to drill much more lateral. This is what starts to take us out into the jugular tubercle here. So down here, this is jugular tubercle. We'd have to drill out all the mid-clivus. One thing you always want to do is you want to really maximize your exposure. So I'm constantly coming out and drilling more superficial bone to give myself more access. Coming closer now. So this is starting to get here a little bit into jugular tubercle, just the most medial part of it. I would have to really take down the basopharyngeal fascia inferiorly to really show all of that anatomy to you.
How do you recognize that you're at the jugular tubercle when you drill it like this?
I'm sorry?
How do you recognize that you're at the jugular tubercle when you're drilling inside out like this?
Yeah, so essentially, as soon as you come behind foramen lacerum, you start to see all this cancellous bone. Come in here, come in close. So see all this cancellous bone here. That's how I know I'm coming into jugular tubercle, and I'm also directly underneath foramen lacerum. Let me see, do we have the navigation set up?
Navigation?
Are you able to see that up there? It's still the
Can you show the navigation screen? Navigate, external camera, audio visual.
And again, if you can zoom in on the axial would be great. Can you zoom in on it?
On the
It
navigation.
doesn't have to be just the axial, but if you can zoom, there we go, beautiful. Is it possible to do a bone window on that?
Here's a bone window, you're in the soft tissue window.
Yeah, the bone will help us really see the anatomy better. No, that's just making it darker.
It's not clear.
There we go.
Yeah.
So if you look on the axial there, you see how I'm into the jugular tubercle. It's a very small little green dot. It's very hard to see on here, unfortunately. But you can tell I'm into the jugular tubercle there.
They can see it on the screen.
And you see it on the sagittal as well.
Sagittal, yes.
Can you put the endoscopic also as a PAP there? Endoscopic as a PAP?
Yes.
Audio visual, endoscopic as a PAP.
It's PAP, no? Yeah.
Endoscopic as the PAP.
Yes.
So I'll show that. So now go back to the endoscopic view and you'll see where we are.
Yes, yes.
So you see how this is just behind and below the, can we go back to the endoscopic view, please?
Yeah.
So you see that's really jugular tubercle. It's just below foramen lacerum here. And to expose the hypoglossal canal and the rest of the far medial approach, I'd have to go much lower. But this gives us nice access. We'll be able to see the sixth nerve beautifully. I'm just going to drill out a little more here. Coming closer just so I can see. Let me see a through cut.
Through cut. You want a coablation?
I'm sorry?
Do you need a coablation?
Coablation?
Yeah, we
What
have
do you
it.
mean? Like coagulation?
Yeah,
Oh, that's okay. I can just through cut. It's okay. This is working out. Oh, we have quite a coablator even. Nice.
yeah, we have it. Yeah.
Making sure we haven't destroyed our flap yet. You can see the flap really is a bit at risk as we work on the clivus. So some of this bone here is blocking me out. That's why I want to drill this out a little bit. Pituitary. Drill. So I'm not going to expose the other side, but you can certainly do both paraclival carotids and preserve the flaps. It's very possible. Come in closer, please. So I'm leaving the pterygoid wedge on this side. I'm just drilling out a little bit of the superficial clival bone here. Come in a little closer, please. You notice I'm constantly keeping my left hand moving, constantly suctioning.
So mid-clivus.
I can help out the endoscope by tapping it with the end of my suction. That helps clear that extra dot. Come in close, please. Close, closer, closer, closer. I never want to do any blind drilling here. Just like with an open approach, you should always see everything that you're doing. You can see I'm all on cortical bone here now of the clivus. I try to keep most of my movements here parallel to the carotid so that if I slip with my drill or my drill jumps, I don't end up in the carotid artery. So I'm very intentional about the direction of my drilling.
Parallel to the paraclival.
Say it's a little more medial. You have a caudal, Carrison, pituitary first. So a lot of times, especially in an older patient or a cadaver like this, you see the periosteal layer of dura. There are two layers. There's a periosteal and a meningeal layer, and chordomas tend to grow between the two layers. You see the periosteal layer is pretty much stuck. Pull back a little bit. Yeah, pretty much stuck to the bone here. Let me see the through cut, straight through cut. So what I'm removing with the bone is the periosteal dura, and the meningeal layer will stay intact. Kerrison. So the periosteal layer is not really, there we go, I'm leaving it a little bit better here. There's periosteal layer. You can see it a little bit more cleanly there. Too close. So here I'm just removing a little bit now of the petrosal process. Not quite, actually, I'm heading up towards the petrosal process. Clogged? Maybe I can unclog that actually. Okay. So this is just mid-clivus here. I'm coming up on petrosal, and you won't see the petrosal process unless you really mobilize the carotid itself. So there's just a little more of the upper clivus coming up. You can still leave it. It will still work there? Okay. It's only when I'm working in that direction that it sometimes will run into your hand. Yeah, there are a lot of little logistics about your setup to help yourself have freedom of movement. You know, your hands have to be able to move 360 degrees around the nose. So you really need freedom of movement. And you have to be creative with how you hold and use your instrument sometimes. I'm trying to get as low as possible so we make sure that we're down to the vertebro-basilar junction, which is how we see the sixth nerve. So I need to make sure I'm at least down to the mid-clivus if we want to see that vertebro-basilar junction. Caudal.
Is there the tip of the jugular tubercle there?
I'm sorry?
Is there the tip of the jugular tubercle there? That one?
We're not at the tip of it yet, but we're getting closer. We're in it for sure. Pituitary.
It's very deep, jugular tubercle.
All right, so caudal now. Let me see the carotid. So now if I want to really expose all of this, you see how I can't really do much with the carotid. I can't mobilize it because all of this bone is blocking my access. So now we have to really do the formal transpterygoid. Stay more medial, a little more medial. More medial, yep, And when I want to really find the vidian, I'd like to get on the body of the pterygoid, coming closer here now, and dissect from medial to lateral, and sure enough, there's our vidian. So get on the body and dissect. I'm going to take a kerrison first now, and I'm going to work in the pterygopalatine space to open it up more out to foramen rotundum. So if you want to see foramen rotundum formally, Vinod did a beautiful job of finding us the maxillary nerve and the infraorbital nerve, but you have to remove all the way up to the infraorbital fissure. Now I have to be careful here. If I'm too aggressive, you can fracture the orbit. Show me the orbit, please. Just come in a little bit. Come in. No, same side. No, you're fine. You should be able to see it from there. Just come, push over. There we go, yeah. So he's just pushing over the septum. There we see orbit, pituitary. And now this is firm bone here, so I'm going to drill it. You don't always have to drill it. Stay a little more medial. Yep. Just a little. But you're twisted a little bit. You twisted it. You're twisted. Your view is twisted. There we go. So here's our orbit, and as I drill this out here, between Vidian and V2, the space between them gets wider in a cadaver like this where there's pneumatization of the lateral recess. Pneumatization of the lateral recess is just pneumatization of the base of the pterygoid. If it's not well pneumatized, then V2 and Vidian are going to be very close together. If it's very well pneumatized, then they will be very far apart. So actually that relationship between the two changes. So here I'm drilling out a little bit of just a septation on the orbit. Come a little closer here now.
That's the V2, right?
I'm sorry?
Is that the V2 already here?
Not quite, yeah,
V2,
close, very,
V2.
very close. Pull back just a hair, yeah, right there.
Really stuck.
Let me see a kerosene in the meantime. Kerosene, please.
Nino, until
Oh, pituitary. Pituitary.
Sorry.
Yes. Not what you want. Kerosene.
Foreign body.
I'll take a different drill bit.
Kerosene
Kerosene 2, please. So here I'm going to open up onto the inferior orbital fissure. I want to drill that out, so you don't want to fracture the whole floor of the orbit. Stay just a little bit more medial. Pituitary.
Clear, actually.
Pituitary. Okay, so caudal. So now as I dissect along the base of the pterygoid, I should land in foramen rotundum. And sure enough, there's foramen rotundum right there. Pituitary. So that's going to be foramen rotundum. Now, if I want to access Meckel's cave, you have to sacrifice Vidian, because otherwise it's just going to push you up onto the cavernous sinus. You won't actually be able to access Meckel's cave. So I'm going to leave the Vidian for now. We're just going to do some cavernous sinus work, exposure first. So I'm going to drill along. Now V2, foramen rotundum, has a very thick septation over it, right at rotundum, and then the bone over Meckel's usually gets very thin. So everything I drill here is actually going to take me, the Vidian is going to force me up onto the cavernous sinus, which is V1 and higher, and not let me get onto Meckel's cave. So if I want to get to Meckel's cave, I'm going to have to sacrifice the Vidian, but let me show you the cavernous portion first. So again, I've done all of this while preserving Vidian. Coming closer.
Now you are doing the dissection over the V2 area now.
So this right here, this is below the optic strut. So this is superior orbital fissure, caudal. Caudal. So this is going to be superior orbital fissure right here. There's superior orbital fissure. That's what's going to transmit the contents of the cavernous sinus, kerosene, into the orbit. I'm just going to nibble away a little bit more of the optic strut here and the OCR. Clean, please. To be very careful here, obviously. Don't want to get into the cavernous sinus. A lot of times I would just drill this with a thin drill. Stay medial, stay medial. Here's our optic canal there. So can we, so maybe now you can switch to that diamond burr so I can be a little more delicate with this. Can we put that diamond on, the diamond burr on? Take a pituitary. pituitary.
How much of the optic strut can we remove with the endoscopic approach? Can we go to the...
I don't think that it's safe to get into the clinoid. I think because you're drilling between too many critical structures. I think if you really need to do that, you probably need a different approach.
But I think there's a Chinese surgeon who does this, I know that.
I completely disagree with that. I think it's very dangerous and it doesn't make any sense. There's a Chinese group that talks about doing a anteroclinoidectomy through an endonasal approach, and it violates every principle. The endonasal approaches, remember, were developed because of limitations of an open approach with tumor medial to the optic. The whole point of the approach is not to cross the nerve, or the carotid. So if you start doing things just to be able to do it, to cross the nerve, I think it's a mistake, and I think it becomes quite dangerous. So I think the risk then, if the tumor involves the anterior clinoid, just do an eyebrow craniotomy or something, simple and small for it, or a pterional craniotomy. The clinoid, I think, is beyond the reach. You can remove only about 20% of it. Now, you can drill, you can see in a big strut, I can drill out a bit of it, but it really is not the safest thing to do here.
In fact, he sometimes sacrifices ophthalmic artery and goes in.
I'm sorry?
He sometimes sacrifices ophthalmic artery and then goes further.
Caudal, yeah, but these things don't make sense. Caudal, they don't make sense to, and then pituitary. There's a very beautiful approach to the clinoid. Stay more medial, a little more medial, yeah. So we really don't have to come up with new approaches for the clinoid. Let me just, pituitary. You can see even working here, I'm working lateral to the carotid, it's a little bit, you can certainly do it, but it starts to become more dangerous, okay? All right, so now I'm going to show a little bit of, let me see a pituitary one more time. Okay, so here's a little bit more of the optic strut. There we go. That's about all you would ever want to remove to expose all of the supraorbital fissure. So let me have that smaller section now.
You're already seeing the third nerve there, I think.
Okay. And the scissor, do you have a sharp scissor there? Maybe the straight one I think was sharper. The left one, unfortunately, was not very sharp.
Is the third nerve already there?
Yeah, but let's start medial. If I want to do a medial, if I want to expose and remove the pituitary, the medial wall of the cavernous sinus, I have to expose the upper paraclival carotid, and I have to expose the floor of the sella. So I do have to remove bone pretty extensively around this to have access, okay? So now I can do a little bit more of what I need to do to expose. There we go. Let me see that scissor now, straight scissor.
Micro scissor straight.
All right, so here is within the sella. We can see a little bit of the medial cavernous wall. Stay more medial. Yeah. So there's our medial cavernous wall right here. We try to separate it from the gland. So there's medial cavernous wall. And so there's going to be the inferior, right there, medial cavernous wall. So if I want to remove it, I need to dissect it free from the gland, which is pretty easy. Usually the tumor will do that for you.
Can you show the ligaments in the thing?
I will. So here we see the medial cavernous wall from the sellar side.
Yes.
So if anyone says that there's no medial cavernous wall, you can find it in every single cadaver. It's always there. So now we want to open along the carotid. Do you have that 45 ethmoid, that 45 scissor, the rotatable scissor? If you can hand me the handle of it, please. Thank you. Okay, so I want to open along the face of the carotid just like this. So I like to use that. Mizuho makes a hooked feather blade. You can reuse it even though, all right, and then I'll take the scissor. So now I can see the carotid perfectly, that straight scissor. And now dissecting medial to the carotid, we'll start to see the attachments of the ligaments. So here is the inferior paracellular ligament right here. There's the floor of the sella, also part of the inferior paracellular. So those are inferior paracellular, and now I'm going to run into the inferior hypophyseal artery back here. There's our inferior hypophyseal artery. See that right there?
Yeah,
So
inferior
sometimes you
hypophyseal.
have to cut and coagulate and cut that. Okay, and then as we move upward, pull back just a little bit, please. We start to see the carotidoclinoidal ligaments. Now the carotidoclinoidal ligament, this is where the proximal ring, you see how this is attached to the carotid here? Now, as I move this, the carotid moves with it. This is the proximal ring wrapping around here, and this becomes the carotidoclinoidal ligament.
Oh, carotid-
Here's carotidoclinoidal ligament. I'm cutting that. It comes at an
CCL.
angle. And then this is just the attachment at the diaphragma. So I just cut the carotidoclinoidal ligament. And then you can see how that's completely released this medial wall of the cavernous sinus. So critical is the inferior paracellular ligament, controlling the inferior hypophyseal, cutting the carotidoclinoidal ligament, and then sometimes there's a little superior paracellular ligament, just attaches to the diaphragma, pituitary, and there's our medial
CCL
wall.
is at the level of the diaphragm cella, no?
The CCL is just below the diaphragma. It's not at the diaphragma. Scissor. The carotidoclinoidal, scissor, please.
Is it the confluence of a diaphragm with the proximal
It is
ring?
not, no. The carotidoclinoidal ligament wraps around the carotid artery. Some of it comes up to the distal dural ring. It is the proximal dural ring as it wraps around the carotid and attaches to the medial wall of the cavernous. Okay. The distal dural ring is here now. So that was the proximal ring. So here's this interdural segment, okay, between the two segments. The proximal dural ring became the carotidoclinoidal ligament, which I cut. The distal dural ring becomes the diaphragma.
Okay.
So this is distal dural ring, and the two almost are in confluence. It appears that they're in confluence, but the proximal comes back to the carotidoclinoidal. So here, as I cut the distal dural ring, coming backwards, now this completely releases for a full hemitransposition all the way posteriorly. So now I've completely released
That's the interclinoidal
the
ligament.
distal dural ring. And there we see the interclinoidal ligament, that's right. Let me see that caudal dissector now. The caudal likes to run away on us, huh? There we go.
Caudal mighty which
All right, so here is the interclinoidal ligament. Stay medial, come medial, yeah. Here's interclinoidal, and that's running again from the anterior clinoid to the posterior clinoid. Okay. So from the anterior clinoid, you have, show me the anterior clinoid. You have the proximal dural ring, which becomes the diaphragma.
Yes.
I'm sorry, the distal dural
Distal
ring,
ring,
which becomes
distal.
the diaphragma.
Yes.
The proximal ring, which comes around the clinoid and becomes the carotidoclinoidal ligament. And then you have the interclinoidal ligament, which you can see very nicely right here. Slow down, slow. Come above me a little bit. Yeah. There we go. There's our interclinoidal ligament, which you can usually see best from a medial perspective. So there's interclinoidal ligament. And keeping in mind that the interclinoidal ligament, the third nerve is going to come out posteriorly behind it at the oculomotor triangle. So this will be oculomotor triangle right back here. And if you have a tumor that goes into the temporal lobe, like a pituitary tumor, it's coming through that oculomotor triangle through the third nerve. Now, for a pituitary transposition, we do need to open the cavernous sinus. So I can lift up and I can now expose, come in closer here. I can expose the diaphragma. If I want to do the same thing on the other side, I need to drill a little bit of the upper paraclival carotid artery. So I'm going to expose just a little bit of the upper paraclival here, just to be able to see the bottom of the paracellular cavernous sinus. Remember, the cavernous sinus techniques to come medial to me. Come a little medial, 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 medial. Yep. Yeah, you notice you always want sort of an off-center view. The view is sort of always at the edge of where you're working, caudal. pituitary. All right, pituitary. Caudal. So I'll show you in a moment, there are 3 attachments to the cavern, to the posterior clinoid. Let me see that scissor again. So if I just want to do a carotid transposition, I'm sorry, the 45 one, the 45, the rotatable. I don't need to remove the medial cavernous wall, I just need to open into the medial cavernous sinus here. And that gives me my access. I want to see the carotid. I want to be in the medial cavernous. Scissor. Just show you the ligaments one more time on this side. Inferior paracellulars ligament. Stay back. Can you stabilize a little? Yeah, there we go. Carotidoclinoidal ligament. You notice the artery angles like this. There's carotidoclinoidal ligament. You see a little bit of it. And you can see the difference between carotidoclinoidal and the diaphragma a little bit right there, but it's sort of a complex. Okay, so that's carotidoclinoidal, and there's diaphragma. Do you see the difference there? So the medial wall is right here. And then I can try to leave the inferior hypophyseal. Let me see a caudal. And then I'll need a kerison. See if you can give that a wipe real quick. Yeah. So you do need to remove the tuberculum if you want to do a transposition, just so the gland has somewhere to go.
But in that area, you'll meet the inferior hypophyseal artery, no? And
I'm sorry?
the live. Inferior hypophyseal artery.
You can sacrifice the inferior hypophyseal artery. As long as you preserve the superior, the inferior hypophyseal does not, I try to leave it, I've left it on this side, but we sacrifice it routinely, we don't kerison. It does not provide critical blood supply. There's enough collateral. One thing I want to show you is look at how the gland has nice dural covering. The posterior gland does not. It's much easier to disrupt the posterior gland. So you have to be very careful when you do this maneuver to lift up the gland very carefully with very gentle suction. If you suction too much on the posterior gland, you'll cause permanent DI. So I like to split the dorsum in 2. The gland does not usually stay up this easily. You usually have to hold it up with the suction. But releasing both cavernous sinuses helps you elevate the gland. So now we're split in 2. I'll take a caudal. And there are 3 attachments of the posterior clinoid. One is the paraclival carotid, one is the upper clivus, and one is the dorsum. Dorsum, upper clivus, and paraclival carotid. All 3 are released now, so now I can dissect the posterior clinoid free. Pituitary. And the same thing on the other side. Caudal. So I may not have disconnected the paraclival. So you see the paraclival still connected. I'll take the drill. So we still have this one connection on the paraclival. Upper clivus, paraclival carotid, and dorsum. Come more medial, yep. Mm-hmm. And you see here with the diamond burr, I can drill basically right down onto the dura of the carotid, and it's much safer. Caudal. Come in. Here's our posterior clinoid. And look, there's a little bit of calcification of the carotidoclinoidal ligament, so you have to be a little careful, I'm sorry, of the interclinoidal ligament. You have to be a little careful with that. I'll take a 45, I'll take an ethmoid if you have it. Do you have a 45 or no? So I'll dissect that out. Sometimes I'll rotate it in, but you really have to be careful of pituitary, of that spike of bone. Pituitary, please.
And
Is
it is
there a
very
chance
close
of,
to the ICA, no?
Is there a chance of ICA injury when
Yeah,
you...
so you
ICA
can obviously,
injury.
if that's not properly treated and there's a calcified interclinoidal ligament, you can have a carotid injury as you try to peel this off. So I make sure and I fracture it. Sometimes I'll grab this with a 45 and I'll kind of rotate it, I'll peel it out. So I'll take it like this and I'll peel it in this direction. So I'm rotating it away from the carotid always, so it doesn't get stuck on the carotid and maybe lacerate the backside of the carotid, which of course would be a disaster. All right, so now we have the entire clival dura exposed, but I don't really have full access here of the carotid. I think before we open dura, I'll go ahead and do that extradural component there and go ahead and sacrifice Vidian. Let me see the bigger suction back again. Okay. And then, so now we're going to sacrifice Vidian. I'll take the scissor, straight scissor. So without sacrificing this, I can't drill the base of the pterygoid, and I can't access Meckel's cave. But you coagulate and cut, there's an artery running with it much of the time. It's not always there, but there's usually an artery with it. Coddle. Coddle. So now we can really have access. So now my only limitation, show me lateral. Show me lateral. My only limitation now becomes the descending palatine here. So here's descending palatine coming down right here. So that becomes my lateral limitation.
I cut it already.
Oh, we cut the descending palatine. Oh, no. So you want to be careful about doing that because that will cause the patient a pretty significant deficit in their palatal numbness. So we usually leave that as our lateral landmark. Here's the descending palatine. So V2 going to descending palatine becomes our lateral landmark. And sometimes if you need to go lateral to it, we'll come from a transmaxillary approach and go around the descending palatine pituitary to try to preserve it. We do try to preserve that descending palatine as much as possible. All right, drill. So now I'm going to drill out the entire base of the pterygoid. Can we get the big burr back on there again?
Can you show the Vidian?
So here's Vidian. There's Vidian going into the Vidian canal, and we're going to drill all around it the whole way back. So everything between V2 and Vidian is safe. There's nothing really dangerous you can run into. The carotid is protected between V2 and Vidian. Here I'm drilling even into the lateral pterygoid plate, which is going to lead me right back towards foramen ovale. As Vinod showed a beautiful example of how that takes us right back to foramen ovale. Is this the one? No.
Can you bring the
Can we bring
suction
it
closer?
Yeah, can we bring the drill closer?
Drill eduthu undra.
We're fighting a little bit. So I'm going to drill lateral to the Vidian here. So I want to protect this with my suction. So I'm crisscrossing, protecting descending palatine and V2 with my suction. As I work my way upward, stay medial, please. Stay medial, 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 medial. Yeah. And I can drill out all of the base of pterygoid in this way. So I'm going to leave Vidian intact as I drill around it. Come up a little higher. So I'm leaving the Vidian in its canal for the most part. You can see how much more lateral to lacerum it goes. So it's really not a great landmark for lacerum. Here I'm still drilling out the base of pterygoid. And you can see how this protected shaft on the drill really helps you as you drill deep here. So I can drill between V2 and Vidian. Show me V2, please, a little higher. Stay medial, stay medial, stay medial, 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 medial.
I mean this one.
Yes, yes, medial, yes. Come in closer, yeah. So you can see here the bone between V2 and Vidian. I can drill all of that out. This is the so-called front door to Meckel's cave, okay? The quadrigeminal space, the front door to Meckel's cave. And this will take me down all the way back to V3. You can't get there without sacrificing Vidian, unless you come from a transmaxillary route. Coming closer here. I'm always amazed by how inferior and lateral foramen ovale is. You really have to drill quite deep and quite lateral to get into it.
Irrigation.
Come on, closer. Yeah. Stay a little more medial. Yeah. Mm-hmm. So you can see here I've really skeletonized Meckel's cave, and I'm almost back to foramen ovale. Come in closer. It's very hard with a small drill bit like this because you like to use the sides of the drill, and this really doesn't have much side to it. You know, it's more side drilling and less with the tip of the drill. So a big drill bit of 4 millimeter is really much better. Coming closer, please. Do we have that diamond burr now? I'll take the caudal. Caudal, please.
Paul, you are using coarse diamond in your center. What is the size of the burr?
4 millimeter coarse diamond burr for almost everything.
40.
4 millimeter, yeah, 40 millimeter.
Okay, okay.
Coarse diamond, not just diamond, but coarse diamond, which means
First time, yeah.
it has some little spicules on it that makes it much more aggressive than a standard diamond burr. It does wear down as you use it and almost become, see, a little higher, almost become a, stay more medial, a little more medial, 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 yeah, just a little, yeah, thank you. So there we see V2 very nicely. You can see the difference between V2 and Vidian. Let me see the drill now. So I'm gonna have to really skeletonize Vidian now if I really want to see all of this. Coming closer here, please. And V3 is going to be much more lateral than V2. So you see, you know, the problem is drilling this, I can't drill beyond the end of the drill. I can't use the side of the drill because it's the same size as the drill shaft. So it really limits my ability to side drill with it. So this is not the drill I would normally use for this.
Elevator. Elevator. Need me to retract that?
No, it's okay. Just clear it. I can use my suction. If you can just clear the scope, flush the scope, clean the scope. Yep.
Sorry.
So with this drill, though, because the shaft of the drill, I don't have to worry about retracting superficial things. I just don't want to drill into them is all. So let me drill out the Vidian so we can get it out of our way a little bit. Come back a little bit. Just a little, just small. Just flush the scope. Everything else okay, yeah. So I'm drilling back along V2. I've released Vidian a little bit from its canal. Pituitary. I'm going to try to leave Vidian as intact as I can. Let me get a scissor, because I'm just worried I'm going to catch it in the drill. Fog, suction, the other one here. So I'm just going to coagulate and cut Vidian a little bit there, drill. Shoot. Can we get any more slack on this at all, please? Just needs to bring it closer. Bring it much, much closer. No, bring the whole drill closer. Can you bring the whole thing closer?
Keep it here, keep it here.
If possible. Yeah, it's just so far away.
Again, okay. I'm going to push the navigation screen a bit that side and put the drill here.
It's okay.
Maybe here.
If we can't, it's okay. Or maybe just put it on the floor would be okay.
Yeah, yeah.
On the floor is okay.
Just to move this coagulation a bit there.
Okay. More medial, though. Yep, yep. All right, so there we see Vidian and we see V2. And again, this part's not very well pneumatized, so I have to drill out all this bone over V2 in Meckel's cave. Coming a little closer. Twisting a little bit. You twist it a little bit. Coddle. I think we lost irrigation on the drill. Do we still have irrigation on the drill? I'm sorry? Oh,
They're
all
connecting,
this
they're
in,
connecting
please.
it.
Yeah. So there is taking us back onto Meckel's cave. This is going to take us back towards V3. We still have a little farther to go to get to V3. Come in. So that's going to be foramen ovale right back there, but let me drill out a little more. This base of the pterygoid, unfortunately, is requiring a lot of drilling.
Irrigate.
No irrigation possible? Or? Okay. Up a little higher. A little higher. Yeah, that's great. Come in. So that's going to take us into, that's out into temporal dura there. So I believe that's farther than V3. Do we have a bigger drill bit? Can I get a biggest drill bit you have? The biggest one we have? Do we have a big one? I'll never finish this if we don't get a bigger drill bit. The big one. Whatever it is, the big drill bit. Big. Beautiful. All right. Yeah. Pituitary. There we go. This is not in. It's not in.
Locate.
So I'm completely drilling out the medial pterygoid plate. I'm drilling out the base of the pterygoid. And that's going to take me straight back onto foramen ovale back here, eventually. There we go. Kerrison. So finally we see foramen ovale. Okay, so you see how deep that is. It's so deep to get to foramen ovale. Foramen ovale, foramen rotundum right here. Drill. And then there's the vidian. Now I'm being aggressive here, drilling next to the petrous carotid. I would usually be a little more gentle here, obviously, but up a little higher, please. Closer. It's okay. It's okay. It's okay. All right, so this is just a little bit more bone over Meckel's cave right there. Caudal. Pituitary. Actually, a Kerrison is probably safer. Pituitary is fine. Pituitary, pituitary, pituitary. Coming closer here. Caudal. So here we see Vidian. See Vidian, you see V2, and we see V3. There's V3. So we have V3, V2, and V1 going up into supraorbital fissure. So they kind of look like a chicken claw. At 45-degree angles from each other, V1, V2, and V3. V3, V2, and V1. So there's this bone between V3 and the paraclival carotid, and this is the lingual process, or the lingula. That lingual process is the bone that you have to release if you want to really mobilize the carotid artery. Now, we try to avoid mobilizing it by using something like a CTM, but if you have to, you can drill away the lingual process. Here again.
So that is the attachment of the lingual ligament, no?
I'm sorry?
That is the attachment of the lingual ligament.
Yes, the petrolingual ligament will come back from the lingual process posteriorly, yeah. Caudal. So that's the lingual. That's good, that's good, we're good. There's our lingual process right here. Between V3 and the paraclival carotid artery. I'm going to drill out the base of it, which will be over the horizontal petrous carotid drill. Coming closer. Yep. So I can remove the base of the lingual, and I can then remove it, pituitary. So that's our lingual process now being removed. Caudal. So we have paraclival carotid, foramen lacerum, horizontal petrous carotid, a little bit of residual foramen lacerum, and then you can see this is where the petrolingual ligament will attach right there. And if I release that and mobilize, and this is something that Dr. Charity and I were talking about earlier, if you mobilize trigeminal here, you can get some access to the petrous. The problem is that the carotid here is sort of blocking your access a little bit, but right above it, so that's going to be petrous apex there.
Yes.
There's Ipe here. This is what, pull back a little bit, please. Pull back, come above me, come above. There we go. And so if I mobilize here a little bit, I can gain access, come in here. That's our petrous apex there. So that's another window into the petrous apex around the carotid artery. Is Ipe still here? This is what, I have to give him credit for this idea of accessing. There he is, yeah. So it's not, that's the petrous apex. Remember how I told you the petrous body can be gotten to very well from the CTM? This is petrous apex.
Yeah, yeah.
Is it
So maybe this is Ipe's
They
triangle
already
here, huh?
published an article, the front door to the Meckel's cave, that you can go to the petrous through this.
You can, but I don't think it's been well explored, yeah. It's not certainly I've taken tumors out there, but I don't think it's something that's really well defined. So now when we look here, come medial, yep, medial. So here, this is obviously petrosal process here. If you mobilize the carotid, you can see the petrosal process. I'll take a Kerrison. And then I can bite a little bit into this. Let me get a pituitary. I can remove the medial paraclival carotid bone. Oh, we lost suction here. Are you on? Maybe you're on it.
No.
Yeah, I think
Maybe
you're
I'm
on
on
it. I think you're on it. There's a size 14 shoe on it. All right, so here's our petrosal process. Now, you have to be very careful coming up from the bottom like this, ethmoid, or pituitary rather, pituitary, because the Dorello's canal is directly behind this petrosal process. So I need to be very careful removing this so I don't damage the sixth nerve. Caudal?
So the dissection should be caudal to rostral, no?
Always, yeah. So coming up along the petrosal, and you really need to mobilize this to see it, but you can see here that's very clearly Dorello's canal. And we'll see the sixth nerve right there.
Yeah.
We'll see it better. Now, if you're having a hard time finding it and you need to go intradural, sometimes it's safer to open intradural first. So now that we've done all this exposure, let me see up above here. So before we open dural, let's just go through the struts real quickly. Here's the optic canal.
Yes.
So this is the optic strut between the optic canal and supraorbital fissure.
Yeah.
Between the supraorbital fissure and V2, what's this strut? The maxillary strut.
Strut, yes.
And between, down low here, between, come in. Between V2 and V3, there's a mandibular strut.
Yes.
And then, of course, the lingual process, which we've completely removed.
Yes.
And then you can mobilize the carotid to access the petrous apex. Sixth nerve, paraclival carotid, petroclival synchondrosis. This is the medial petrous triangle. You have a little through cut? Through cut?
Fantastic.
So to mobilize the eustachian tube, show me eustachian tube. Here's our eustachian tube, right here. This is the ligament of foramen lacerum, and there's this bit of ligament that runs between them right here. Come above me there. That's the pterygosphenoidal fissure right here. So I can cut that pterygosphenoidal fissure. A lot of times maybe I'll use a little needle tip bovie if I see the carotid very well at a very low setting. That allows me to mobilize the eustachian tube down, and now I can drill out, if I want to, all the way towards the hypoglossal canal and towards the condyle. Is that through cut again? So you see that's mobilizing the eustachian tube. I'm not sacrificing, I'm just mobilizing. Come in closer. I'm also mobilizing foramen lacerum, Carrison. Come in a little closer here. Yeah. So it's just a little more bone here over the horizontal petrous. I may have to drill that if let me see the drill for a moment. If I really want to stabilize, if I really want to mobilize it. Through cut. Through cut. So this is the pterygosphenoidal fissure here. Cutting that takes me back onto the petroclival synchondrosis, caudal. And then I can mobilize this out of foramen lacerum. I can mobilize the carotid laterally. I probably need to release this a little more. There we go. So now I can really mobilize the carotid, little micro through cut. So we used to do this kind of mobilization to get to the petrous apex, but I find the CTM much safer. So that's a complete mobilization, caudal, by releasing the pterygosphenoidal fissure, removing the lingual process, and then I can really access the whole petrous apex. Again, between the sixth nerve, the paraclival carotid, petroclival synchondrosis right here, this is all petrous apex. And we can follow this if we want to, even all the way out to the IAC. Okay, so this is petrous apex, really beautifully defined. There's Ipe's triangle, Gardner's triangle medially, give us access. And now we can, I think, open the dura and really see a lot of these little landmarks. Let me get a smaller section. And you have a Kerrison 1, maybe? I'll start with that. So let me see our pituitary, okay. So we have that retractable blade, that little blade that we were using. Let me actually get the pituitary first. Let me just show this one more time. So when I open the dura of the clivus, I like to peel the periosteal layer separately. You have to be careful because the two layers, Dorello's canal runs between them, and you don't want to avulse the sixth nerve doing this. But you can peel the periosteal layer of dura so that you're just opening only the inner layer once you finally open dura. So now let me get that retractable blade. And then the Kerrison. And I would always Doppler or check with navigation to make sure I'm not directly over the basilar when I make that opening. Kerrison 1. Clean. See if I can find my opening better here. It's okay, we're okay. And then follow me up, please. Come up. Yep. I'll open this kind of like pages of the book. I'm opening all the way up to the top of the clivus. And then inferiorly, I'm going to open to either side. You have a down Kerrison? Like pages of a book, I can open this very widely. And how about a through cut? You can see how drilling out some of that jugular tubercle helps. And then I'll take a caudal. And now we can really spread this open like pages of the book. We see the basilar artery here.
Artery is
this is the vertebro-basilar junction. The sixth nerve is always going to come out right at the vertebro-basilar junction. Very reliable landmark. The sixth nerve exits at the vertebro-basilar junction. Right here.
Yes.
And then it comes up into Dorello's canal. Show it medially. Show it medially here, right here.
Dorello's.
There we go. And then it's going to go up over petrosal process. Here it is in Dorello's canal going over the petrosal process and then laterally. So now let's open into the cavernous sinus, the straight scissor, Kersey scissor straight. So when I open Meckel's cave, I usually open it along V2. The reason is that if I cut any fibers, first of all, I'm cutting parallel to V2. If I cut any fiber of the trigeminal, V2 is probably the most forgiving because it just gives you cheek numbness. We don't have palate or lower face numbness, and we don't get masseter dysfunction. So here we can open into foramen ovale. Come in over here. Come in closer. Down here. Yeah. There we go. Yeah. So there I'm opening over foramen ovale. So here I'm back into Meckel's cave, and I can follow Meckel's cave even all the way through the trigeminal impression, which comes in just above into the posterior fossa. So that can put me into the posterior fossa. 45 scissor, a rotatable scissor. Now, as we open here into the formal cavernous sinus, again, that little hook blade is nice for this. I'm going to come from this side, see if it gives me a little better angle. I want to just open the dura if I can. Not cut the sixth nerve.
That's a dural knife we have.
Come in
Dural
closer.
knife, dural knife.
Let me see. Caudal. So here what we're seeing, do you see these little fibers coming off of the carotid artery itself? We described this recently. These are little sympathetic branches These are the sympathetic branches on the carotid, and they go to the
Carotid
orbit,
sympathetic, yes.
and they get there by hopping onto the sixth nerve. So
Yeah.
these little branches like this, see those?
Yes, carotid.
Those will lead you right to the sixth nerve. So the sixth nerve will then come straight scissor, into the cavernous sinus. So the sixth nerve really identifies the cavernous sinus or separates it from, oh, shoot, I just cut it. Oh, gosh, not what I wanted. So there, I accidentally cut the sixth nerve, being a little too aggressive. We still got some fibers, but not great. Ah, shoot. So there we see a little more of the sympathetics coming. And you see sixth nerve here coming into the cavernous, so that's going to be the third nerve right there. 3, 6, and then 4 is really buried in the lateral wall here. Come in close, please. Stay just a little bit medial, just a tiny bit medial. Medial, that's lateral, there we go. Little, come in. There we go, yeah. You see the fourth nerve just barely running in the lateral wall of the cavernous sinus there. Caudal. Clean the scope, give it a wipe. Yeah. Let's go. Oh, okay. Okay. I think it's too late now. All right, come in. All right, so unfortunately I cut the sixth nerve as it comes around, but the sixth nerve will come into the cavernous sinus here. Here we see the third nerve. The fourth nerve is running right in here. Right in that lateral wall of the cavernous sinus. And it gets really ensheathed in the lateral wall. So sometimes it can be hard to find the fourth nerve because it's densely ensheathed in the cavernous sinus. There's our third nerve running back. And we'll take a look from medial. Come in here. Through the pituitary transposition. Here's the third nerve coming out between the PCA
The SCA.
and the SCA right here. SCA, PCA, there's third nerve. That's going to be uncus there. It's sort of pooched back a little more than it normally would be. So that's the uncus. Since we can see the uncus, we can maybe go lateral and find the fourth nerve. Slow, 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 gentle. Sometimes you can see the fourth nerve coming into the tentorium on a cadaver. It's very hard in a patient to ever see that, but sometimes in a cadaver you can find
Tagging
it.
the tentorium cerebelli.
Yeah, I don't see the fourth nerve back here quite. It's in the tentorium there. So there's third nerve. Come in, please. Yeah. Third nerve is going to come into the medial cavernous sinus. Scissor, straight scissor.
So, can you trace us the path the pituitary tumor takes to get into the cavernous sinus?
I'm about to, yep. So right here. So it gets into the cavernous through, it can go through any compartment. One of the most common ones is through the superior compartment, but it can come into the anterior compartment to get lateral too. So the tumor can grow around the front of the carotid. It can come through the superior compartment. When it goes intradurally, come in here, please. Come in here. Yep. It comes, here we see the third nerve. Let me just swing this over so we can see it better. Come in here. All right, so here we see the third nerve, and this is going to be our oculomotor triangle at the back aspect of, do you have a through cut or something? This is just not cutting it. Through cut, through cut. Come in. So I'm cutting a little bit of the interclinoidal just because it's so calcified here.
Okay.
That's not normal, obviously.
Calcific.
Scissor, straight scissor, straight scissor. So this is that oculomotor triangle. Come in up higher. Yep. Just a little more lateral. Yeah, there we go. There's our oculomotor triangle. That's where the tumor comes through the cavernous sinus, comes through the back of the cavernous sinus, through the oculomotor triangle right here. And it can go above or below the third nerve, but it gets it into the uncus. This is when you see them wrapped around the ICA, the carotid. This is how it's getting there, through that oculomotor triangle. So here, the third nerve, follow me lateral, come lateral. Not so much, small moves, yeah. It'll come lateral then into the cavernous sinus and then run into the lateral wall of the cavernous sinus here. I'm not finding the fourth nerve nicely here. Coming closer. It's in there somewhere. It gets ensheathed in the lateral wall, so the fourth nerve really is stuck in the lateral wall. That might be it right there. I don't see it very well. Here we see V1 coming up, coming through Meckel's cave. V1's coming up into the supraorbital fissure with the sixth nerve running on top of it. Unfortunately, I cut the sixth nerve as it comes from behind the carotid. It should be attached like this. Again, it comes up from Dorello's canal, lateral to the carotid and up into the supraorbital fissure. Show me lateral. Supraorbital fissure here, okay? Caudal.
And for the cardomas, the path of spread for the cardomas.
Yeah, so a chordoma likes to grow in the interdural space. Come in here, closer. So a chordoma likes to grow between the leaves of the dura. So it'll grow into Dorello's canal because it grows between the periosteal and the meningeal dura. And it grows along the sixth nerve right into here. This is how it gets into cavernous sinus. This is how it gets into the petrous apex. It grows in this interdural plane along the sixth nerve and along Dorello's canal. Actually has a little bit of an accessory sixth nerve there, doesn't it?
Yeah.
Any questions about this anatomy? You're certainly, that's about as wide as we can get of a transpterygoid approach.
Should I put an angled endoscope with the lower cranial nerves?
I don't know if it shows us much differently.
Yeah, okay.
Caudal. Yeah, and you notice we did this all with a 0-degree scope. Certainly an angled scope, we could look out more laterally. We can get lateral to V3 if we want to get into the temporal lobe. So this is middle fossa out towards the temporal lobe. It's pretty unusual to want to do that if it's lateral to V3. I would recommend an open approach like a Tone's lateral orbitotomy. But for all of this medial part of the cavernous sinus, for all of the petrous apex and the base of the petrous bone, the petroclival synchondrosis, the jugular tubercle, it's a beautiful approach to access all of this medial area, all through that transpterygoid approach. And thanks to Vinod for a beautiful exposure and for beautiful job helping me with this. And very difficult.
Paul, it is a very great dissection. So for any surgeon, standing ovation is the honor. So we will give the honor to him. Please. Thank you.
Thank you.
Thank you, sir. Thank you. Right.
Thank you.
It's true
Thank
team
you.
surgery.
Yeah.
You cannot do this by yourself. You have to have a good team. You have to have the best ENT by your side. You cannot do this.
Great.
I'm coming to New York.
I cannot reinforce that enough. You have to have a good team. So important. Thank you.
Thank you, sir. Thank you.